taken this journey on, the Women's Health and Empowerment Network for about a year now with us. And it's been, a consistent journey from, when we first launched it to trying to look at the different case studies to actually, developing some of the different financial mechanisms that we're going to be looking at. So I'd really like to thank kind of the co-hosts of this, USNCI and, the Harvard Global Surgery Program and the STPU, who have been, with us. With that, I'll turn it over to Dr. Ted.
Well, again, I want to echo what Joanne said in terms of welcoming you all here, particularly those people who are joining us online at an awkward time for several time zones. We're excited at the opportunity to meet with you all, to hear your ideas, to get your thoughts on how we can best make progress. We have exciting opportunities to both to strengthen the role of women in the health workforce, as well as address burdens of cancer among women. So we're looking forward to productive discussions, building on what we've done over the last year and making plans for the future.
Thank you.
Good morning, everyone, and hello, everybody online. Keith Park from the program in Global Surgery and Social Change. We're just so excited that you all are here as advocates and who are pushing for access to safe, affordable, and timely surgery. We see the WEN network as a key entry point in building surgical capacity using the financing that hopefully will get developed here. Thank you.
Thanks so much.
Hi, Todd Spires with CRDF Global, one of the sponsors of the event, and also one of the partners with the U.S. Department of State for the Sustained Dialogue for Peaceful Uses.
Good morning, everyone. My name is...
Sorry, we're not doing introductions. I was just introducing the co-hosts. So if you've known me for too long, I don't believe in introductions because I believe you can introduce yourselves as we get started in our practical work. So with that, I'd actually like to turn it over to some of the financial structuring that we've been discussing within, how we deploy some of these solutions in order to get to the end-to-end care. We need the structuring of how we actually deploy capital. So we want to take advantage that we have some of those experts around the room, online. Also, you have a virtual audience who you don't see. You see your speakers, but not a virtual audience of those that have also joined us, including some of our women philanthropists. And so we want to be able to, talk at all levels as we're trying to get very practical in what we're doing. So I'd like to kick it off to Jasper, who we've known for quite a few years. Jasper, if you can introduce yourself and really, if you could take us into, some of your experiences, kind of lessons learned as we're looking to, deploy this vehicle for sustainable financing for women's health. We have, political will, we have capital, but there's always lessons learned and how we move forward, and also just your experience in this field of blended financing. Over to you, Jasper.
Thank you, Joanne. Good morning, afternoon, evening, in also my co-host online. Investing for the Netherlands, for the Dutch investing. So we are the National Institute on behalf of NVMO, the Dutch DFI, and healthcare, 5 pillars of organization. And over the past year, we've done quite a lot of work in, especially in Africa, but also to some extent in Southeast Asia.
Jasper, we're having a little bit of trouble hearing you. If you want to retest your mic.
Okay, let me swap my better. Yeah, okay. Did I lose you in the very beginning?
No, we can hear you clearly now.
Okay. Yeah, so Invest International Health is one of the 5 pillars, and we're doing a lot of work in Africa and also partly in Southeast Asia. And I think for us, looking at the theme for today and just in general, the creational impact for us in the health space, largely also through a gender lens. I think one of the things for us, we have development capital. It's a relatively small number a year. It's 9 million. But in the end, what we have found that it's not about the amounts that you put in. So there are two angles to it. One is that with a relatively small amount, we can take a high risk. So for us, we find partners to work along with us that either are a little bit more risk averse than us and can piggyback along that we take we take 50% of the risk generally. And that would also help them work in a very early stage to develop project opportunities. What I found also is that it is the DFIs always hunt in herds, and I think there's a lot of reliance on others for the work to be done. And so what I really like about the DFIs is that there are substantial amounts of money available. What we have found with the development capital that we have is that we generally find ourselves as the only national promotional institute that is active on a certain deal. And we find other types of partners, whether it's NGOs, whether it is corporates, original OEMs, for instance, that co-invest in an opportunity with us, and also at times the local government or another local entity that gets involved. And if everyone chips in a relatively limited amount of money, in the end, it's not so much about the money when you're in an early stage development, but what we really like is the opportunity to have totally different types of organizations at the table. So we tend to have a joint impact objective, and the narratives are relatively easily aligned. But then especially having different parties that look at opportunities, impact opportunities from a completely different perspective, is what if you talk about blending, and I don't want to get carried away in a whole discussion about semantics on what is blending and what is catalyzing and what is mobilizing, but in the end, it is bringing other parties along. And for us, one of our mandates is also that we have to be additional. And additional basically means for us that if we don't do it, nobody else does, and it doesn't move forward. So we need to have a unique role. We find other parties that also have a unique role. So one of the things we spend a tremendous amount of time on, for instance, is one of the counties in Kenya, where together with an OEM and an NGO, we developed an opportunity for improved primary healthcare. Because we strongly believe as an organization that's safe from prevention, because that's a whole other discussion. But if you invest in primary healthcare, you in the end get the best improvement into the health of the population. And that we definitely saw that with an NGO and an OEM, we had so much to bring to the table, and we could leverage on each other's strengths, not just financially, but also the expertise that we had, the context that we had. So in the end, it was a tremendously interesting journey. The pitfall was also, and that's something I have to admit from my side, that I slightly had underestimated the value of the other parties at the table, because having an OEM on board makes it very much equipment driven. And having an NGO on board basically brought our solution, because it was a PPP. There was a relatively large training component, because that's what the NGO primarily did. So one, it gave us a lot of insights, were extremely helpful. We got a lot of people on the table moving forward with the project. The flip side is that we basically over-engineered the solution. So that was an important lesson that we learned from that one. Now, luckily enough, in Kenya, there are another 46 counties that we can look for ways forward. So there's a lot gained. But bringing different parties at the table, one, of course, with funding, because you do need your funding, but definitely also with different expertise and connection has proven to be very helpful. Joanne, how much do you want me to continue
No,
with some other
that's great. We're going to
examples?
come back to you, Jasper.
Okay,
So I
thank you.
think this was good for framing the discussion, because a lot of what we need to do is that financial sustainability. So you gave us kind of what's involved from, a capital perspective. So I'd like to turn over to, get us more practical from the capital side. Robert, when you deploy capital, you wear two hats, right? You have an equity hat, and then you also have a philanthropic hat. We're here to think of not only case studies, which is the third session, but now we're really on how do we financially look at it, both from, and I know Annie's here too, and we have, other, John Dewey, how we look at it from an investable perspective, because we need to combine not only the social impact, and as Jasper said, we have the NGOs that are deploying the good work, but at the end of the day, these solutions need to be sustainable over time. So could you give us some insight onto, potentially some of the structuring ways we could look at?
Yeah, so first we look at, is it a for-profit or a nonprofit, and then whether we're deploying. Then we bring our investment team in, and then we, should I be turning this?
Yes. I don't think they can hear.
Okay, great, I'll start over. So, me personally, I'm a bit agnostic whether it's nonprofit or for-profit. Ultimately, I'm looking what the solution needs to be and how they need capital. I think about ways to get the capital to these organizations or for-profit. That's me as the founder, but we have an investment team, and we also have a whole philanthropic team that acts much like an investment team that diligences the opportunities. So I structure my company in such a way, Conscious Capital, where we have our public benefit corporation in Philadelphia, which has consultative status at the ECOSOC, and we've been making grants to nonprofits for 3 years now. And I set that up at like an asset management model, almost like a fund of funds, and with thematic funds. So whether that's women's health or women's security, and then we deploy those funds in that way, capturing money from family offices, much like you would see, or individuals, much like you would see on the investment side. And then on the investment side, we make investments into individual companies. But so when we look at a nonprofit or a for-profit, and we think about how that money needs to flow there, we go to our, let's say, our investor base or our donor base, and we pool those funds together in-house and direct it. So in terms of structuring, there's a myriad of financial vehicles, as much of us know, but I think you have to be you can be creative and come up with new kinds of models that will ultimately result in capturing more money. And so that's how we think about it. But we're really, what inspires us, what motivates the team is really the mission. And then we work back from there so we don't think of ourselves as, this is our vehicle and we have to capitalize it and this is how we're going to deploy it. We kind of do it in the reverse. And when you do it that way, it just gets really interesting. You can actually capture a lot more money and then be more effective at deploying it. So we're excited. We've deployed quite a bit of capital in the last 3 years, and on the philanthropic side, we're looking to increase that. And one of the reasons why I'm here is because I'm going to listen to what all of you are doing and seeing how we can partner and work together and make these investments more impactful. And so I'm here to also use my thinking cap from what I've gathered from working in finance for about 30 years. I don't know if that's answered your
Thank
question.
you, Robert. Yeah, we're going to dive into it. And Annie, you and I had a conversation. I think, we're talking at a high level. When you actually get into the programs on the ground related to women's health, it's, it's hard in terms of, how the innovations are deployed at the end of the day. So as the collective team here is, yes, we have capital at the table. Yes, we have women philanthropists. It's not easy even when you have capital, right? So if you could talk a little bit to that as we're thinking through the design of how to do this. And there's mics. Oh.
Hello. Okay. Hi. I'm Annie Theriault. We run an impact investment fund, and with respect to structure, I guess a couple points I can make. So our fund is a venture capital fund, so we invest in technologies that have a venture capital return profile. And so the capital that we take into our fund is two kinds of money. We have a layer of concessionary capital from groups like KFW or a charity that they funded a number of years ago called GHIC, and from Grand Challenges Canada, and that capital serves as a first loss layer. It's backstopped by a guarantee from the Swedish government, and together those two pieces create a 30% downside protection for investors. And then the remainder of the capital comes from the return-generating portion of endowments. So it's capital that's managed very traditionally. It comes from funds of funds that are impact funds of funds that are seeking, 20+% IRR for their money. And the reason we structured the fund in this way isn't because we're earning lower returns than any other VC at the table, but rather it's because our fund is structured to invest only in technologies that have a health impact on women, children, and adolescents. And we take that one step further and we only look at technologies that are internationally relevant. So within all the opportunities to have a positive health impact on cancer, we look for the treatments that are lower cost. We look for software platforms that upskill labor forces around the world, but that have still that venture profile. And so I think that's, from a structure point of view, the reason it was needed was, I guess, a couple of very important reasons. We're a women-led GP team. We raise a lot less money as a women-led team compared to men. But also, when I approach investors and I say, I'm going to do women's health, we're a women-led team, and we have a global impact strategy. Let me count the ways they want to run out the door until I say, but we have the 30% downside protection. So I think for those around the table that are able to provide that lower return profile money, it's really important to get involved with newer managers that are doing things a little bit differently, because it does enable the launch of new thinkers around the table. I will say that in the syndicates where we work, we're sort of typically the unique voice at the table, but people do value our point of view because we help companies be more international. And just recently we saw that play out in a company that I've been talking to for about 7 years. They were a recipient of a grant from Grand Challenges Canada. They've got a technology to test for preeclampsia. Their clinical trial in the US failed actually to meet the endpoint of proving whether it was useful because the practitioners couldn't detect the color with the naked eye. They ran another leg of the trial in Africa and the Africans could actually detect the color change, so it really saved the technology. So you see these synergies in our strategy that you wouldn't see in other companies. And I don't know if that's where you wanted me to go.
No, this is great, and I want us to know
helpful.
that this is kind of closed door, that you have a virtual, but the virtual is closed door. So, as we're structuring, let's get very concrete. And I realize that we have different backgrounds around the table. So you have some handouts that talk about kind of blended financing, kind of a typical blended financing fund, and then also, different types of capital, because we're talking about, different waterfall capitals that you'll hear different people from grant to debt to, also equity. And so you have some of those diagrams to kind of give it perspective. One of the things, again, driving us to get practical, I know that Unitate has been thinking about, some catalytic type of new mechanisms related to women's health and, blended. If you could talk a little bit to that.
Sure, thank you, and good morning, everybody. My name is Tenu Avafi. I'm the Unitate Deputy Executive Director, and my colleague Matthew works with the External Relations Department. So I'm definitely one of the newer, how can I say, new to the terminology, so to speak, but very happy to be here and to share a bit about our story. So by way of quick introduction, Unitate does two things. We help to bring to market missing treatments where there are unmet health needs and the market does not incentivize their development. And the second thing, where we really focus, is on accelerating or optimizing the introduction of new technologies, tests, therapeutics predominantly into LMIC markets. And by doing it as efficiently and as quickly as possible, breaking down barriers. And by doing that, we help to save time, We help to save money, and ultimately it results in saving lives. For the last several years of Unitay's existence, we have focused on HIV, TB, malaria. We have a very synergistic relationship with the Global Fund, for example, because we help to break down the barriers of entering a market, and the Global Fund comes with the heft, the investment, or it can also be PEPFAR, that helps to scale up. And so we have this relationship with the fund where, for example, our work on HIV treatment, dolutegravir, has resulted in about $1 billion a year of savings. Unitaid has expanded into more niche areas, including women and children's health, domestic and regional manufacturing, climate and health. And I want to go back to the women and children's health piece. We work in postpartum hemorrhage, preeclampsia, and cervical cancer. Cervical cancer, we've been making investments for the last 4 years or so. The investments, given the scale of what we do, at the moment we are an organization that disperses about $250 million a year. The cervical cancer investments are quite modest. So far, we've invested about $70 million. We focus on prevention, screening, and then also treatment of precancerous lesions, thermal ablution devices. We have been working in 14 countries in 3 continents, and we have managed to get about 1.2 million women screened in these countries. So not a massive impact, but still an important one for what is a very neglected space internationally. Now, unlike HIV, TB, malaria, where you have these large investors that come in with the heft, because cervical cancer is a space that doesn't attract the same level of investment, we're interested in looking at sustainable financing and other innovative forms of financing as a way of leveraging impact, because the investment, I mean, it speaks for itself in terms of what we invest and what the impact, the health impact is. But this is a space that we think is one that we'd like to start a conversation with like-minded allies.
Great, so we look forward to working with you as, you know, we're structuring this vehicle and seeing how we can help and partner. And you mentioned US PEPFAR, and I know Jeffrey has joined us, who I think it's probably now 2 o'clock in the morning over there, right? So we really appreciate your dedication, and if you could introduce yourself and tell us a little bit, not only of where, you know, you kind of see where we're going, but kind of advice. I mean, you bring some of your personal sort of deployment of the sustainable financing conversation to the table. Jeffrey. Oh, we can't hear you. We can't hear you. We can't hear you, sorry. It might be his headset. Can you? Could it be your headset? Oh, okay. Sorry, we're having problems hearing you. So I'm going to turn to John Dewey. I know you're looking at different perspectives, and then we'll come back to you, Jeffrey, in a lot of the funds that you're doing. And you know, you heard the different perspectives of why we need catalytic capital at the table. If you could talk and maybe give some advice to this group as we're structuring some of the financing mechanisms and the sustainable financing for the case studies.
Sure, John. Thank you for including me today, and it's a pleasure to meet you all and understand the objectives that the group is trying to solve for. I guess we bring a slightly different perspective, having been in the investment management business for the bulk of my career. We've structured a number of deals and vehicles in search of creating opportunities for inclusionary financing, for climate initiatives, and other impact efforts. The company I'm with, and I've co-founded with a couple other people, is called Meridian Capital Partners. And our objective is to find emerging managers who are focused on impact. We've run into a number of managers that have great ideas, have very important missions, but do need catalytic capital to either expand in markets like Africa or to get off the ground with seed capital. So from our perspective, we're looking for ways that we can bring these managers to the table for organizations like one. And I think we've got a great pipeline of prospective solutions of folks that are looking for solutions in healthcare, climate, and financial inclusion. And so the alignment is interesting from my perspective. We can bring some solutions to the table for you all. With regard to structure, I do think that there's an opportunity to overcomplicate things. Certainly, we want to bring all the components to the table that are possible, but it appears to me that we can keep it simple in how we structure fund to fund, similar to how was previously mentioned. For the deployment of the capital, it's probably one of the most efficient ways to do that. I think the screening of managers is a critical component to that, making sure that the investment policy clearly identifies allocation across the verticals that you're looking to fund, as well as catalytic capital and operational capital. So why don't I stop there and see if there's any questions?
Yeah, and we'll go back and forth. And I think one of the things to get us practical is why we're doing this. You know, I know Africa Resource Center, I know Faustin, you've also been thinking about some catalytic kind of mechanisms to look at supply chain management in the African continent. If you can talk at a high level, because there are a lot of supply chain issues that we've seen under, you know, the last pandemic of, you know, these are mechanisms we're structuring, but, you know, how do we get practical and how do we, you know, catalyze change in this area?
Yeah. Thanks for having me. My name is Faustin Mukena. I'm the Chief Executive Officer of Africa Resource Center. We are a non-profit organization from the continent. We are based on the continent and we work with the people from the continent. And the reason I'm insisting on this is that we support governments. We are working with government to advocate for women, to advocate for supply chain, to be as part of their strategy, part of their policies. And what we see as a challenge as we do this is that it's more about funding of that strategy. Execution of the strategy never get to maybe 30% would be like a great achievement. We do that on the continent across, for the moment, 14 countries. We have offices in Nairobi, in Dakar, and in Cape Town in South Africa. And we support countries from West Africa like Nigeria, Senegal, Burkina Faso, and a couple of others. So back to the point that Joanne was making is that as we work with governments, trying to ensure that medicines get delivered not only to the last mile, but as close as possible to the door of the patient, it's very important. What we see is that people are more worried about procurement and less about how does it get to the central store and how does it move from the central store in the main city to all the villages across the country. And that's is not what is thought through. And we are advocating to ensure that this can happen by working with private sector in the country and ensure that the partnership between private sector and public sector shouldn't be seen as a competition, but should be seen as a partnership, working together. And also supporting local innovation. There are a lot of local young people who are trying to develop things, diagnostic, on the continent, but they don't get support for lack of funding. So those are the advocacy that we try to do. We have an independent view vis-à-vis the government, because the government, as much as they are our clients, because of their priorities, we don't build the governments. So we source our funding so that we can give our point of view independently to the government. So they kind of support that and agree on that. So we started about 7 years ago, very young, supported by the people who love that mission. We're supported at the beginning by USAID, the Gates Foundation, the Global Fund, and we're looking for more funding as well to continue as we continue to advocate on this. On women particularly, it's important to note, and I'm not gonna say something new here, that on the continent, women is the economic power of any household on the continent, and the health of women is as critical as development of the economy. So it's important for us as we advocate to this to see how do we put together some programs that can support women economically so that they can be free in terms of, or independent in terms of their health as well as they grow.
And I think in your unique role, maybe it's, also having the finance ministers work with the health ministers as we're designing some of the blended financing, because it doesn't have to be only a large-scale vehicle. I know some of you have deployed blended financing vehicles per country, right? Working directly with the ministers in those countries. So, as we think about this, yes, we're thinking of a fund of funds and aggregating capital together as partners, but maybe it's an individual blended financing vehicle. So I'd like to turn it over to someone who I know has done a lot of work in health and security, Uri, and really, passionate about women's economic empowerment. In terms of the discussion you've heard to date, kind of your thinking and thoughts.
Thank you. Just a caveat, Finland is in the middle of government negotiations, so I'm more talking about the past, not making any commitments to the future. But Finland has had a long history of promoting gender equality, starting 1864 when we gave women full rights at the age of 25, and in 1906 when they were allocated full electoral rights, so a long history. And we really believe in that women make the economy run. Like my colleague from Africa just said that, without women in the economy, it just doesn't work. And it makes all the sense in investing in women. A gender pay gap is a persistent gender equality problem, and also as long as women are primarily responsible for unpaid work, it hinders their ability to gain economic independence through paid work. And we need legislation and public services to enable women to be an active part of the economy, and also we strongly believe in the, both parents being part of the family equation as well. Finland supports innovative activities in developing countries. We have promoted stronger and more diverse economies and the creation of new solutions that support sustainable development. Our bilateral and regional innovation programs have strengthened innovation and startup economies in partner countries. The projects financed by us have created 57 research, technology and innovation partnerships in developing countries. We have supported business enabling environments in the private sector in developing countries, and the role of women in the economy have been promoted with measures such as access to micro, small and medium-sized enterprises owned by women, to business support services such as finance, training and networks. In addition, FinFund operations and development policy investments have been used to focus investments, especially on companies owned or managed by women. On the the blended funding issue. We have contributed to regional economic integration. For example, Trademark East Africa has streamlined regional trade connections in East Africa, reducing trade costs. Multilateral trade and development organizations funded by Finland have strengthened the national and global business environment, improved trade policy expertise, and contributed to sustainable industrial development. Assistance to UNIDO resulted in 121 legislative or policy proposals to improve the business environment or economic integration in 2019-2021. We have also, Finland is also a leader in the Action Coalition on Technology Innovation for Gender Equality. And the blended finance is channeled mainly through investments and concessional loans through multilateral development banks and funds operating under them. And we have investors in Finland such as FinFund and FCA Investment, which is an impact investing company established and owned by a Finnish NGO. In Finland, LUC, Blended Finance Fund, which we have established together with the IDB Invest, 30% of the investments have a specific gender component. And with the ADB Venture Fund, special gender approach has been implemented in a third of the investments, and the other 2/3 include a gender mainstreaming component. FinFund offers long-term investment loans and venture capital to private companies for projects in developing countries. It is part of the International Gender Finance Collaborative and one of the founding members of the 2X Collaborative that aims to increase the volume and impact of capital directed towards women's economic empowerment. Some of the projects we have funded include education, health-related projects in Africa, microfinance projects in Myanmar and regionally in Asia, investments in an insurance company in Sri Lanka to support gender equality in life insurance schemes, healthcare companies in Rwanda and Kenya, regional food fund and telecommunication projects in Africa, and some SMEs in Nigeria during the economic crisis during the pandemic. And then maybe a different type of an economic incentive is the International Gender Equality Prize, which we established in 2017 due to the 100th anniversary of our independence. The prize will be awarded to a person or organization that has advanced gender equality in a globally significant way. The amount is 300,000 euros and it's awarded every second year. The recipient of the prize is a person or an organization who has promoted gender equality, and there are no restrictions on the nationality. The prize is a monetary award, but it's not granted for the awardee of the prize, but that person then designates an organization that they can give the money to. And anyone is welcome to propose a candidate. The process is currently open, and you can go to genderequalityprize.fi for further information.
Thank you so much, and we're looking forward to, I think, some of the partners, and it was really useful to learn the different mechanisms of blended financing, that you have. I think, one of the things as we're looking into is from the country perspective. As you said, you have microfinancing in some of the countries, and so I'd like to hear from, the Deputy Director General from Zambia. One of the things that is going on in the country is you're leading. So how do we work in some of the countries to make sure if we're creating high-level blended financing or local blended financing that we're working hand in hand?
Thank you, Joanne. My name is Roma Chilengi from Zambia, and I actually serve as the advisor to the President on Health. I also double as the Director General for the Public Health Institute. Now, allow me to just say that from Zambia, we want to present our country as an opportunity for making a real difference in terms of development and the approach that we are taking. I think that really from the outset, since we turned into a new government, it is very critical for us to demonstrate that even countries that are deemed to be poor are not as poor as they seem. I think from the same budget that our government inherited, we were able to plug hemorrhages into public resources, and really in the same budget that was struggling, able to turn things around very strongly in ways that were not seemingly possible even to ourselves, that our constituency development funds that were erratically given to the constituencies to the tune of 1.5 billion to each million to each constituency in our local currency, we turned it around to 28 million per constituency now, and that's a very key strategy for our devolution approach, where the money has to go to the people. The money must not stay in the capital city. It has to go to the people and create mechanisms where the people make decisions on what are their priorities and where is it penning the most, and so central government distributes the cake and allows the people to make decisions on what they need, what they think is key priority. I want to also say that our government has also taken on a decentralization approach that is really taking the decision-making to the grassroots. This is really critical. But to speak to the conversations in the room concerning health and women, at the general level, some of the things that our government is doing is really implement the national health insurance mechanism, and we have a health insurance authority that is really collecting mandatory taxes on contributors, and in a population of just under 20 million, we are really struggling because we have only in the last several months managed to lift the number of primary contributors to about 1.8 million. Now the target is to get it to about 4 to 5 million contributors. Then the vision of the health insurance scheme will function as foreseen. The challenge, of course, is that we don't have a very a broad base of people in formal employment who you can easily sort of tap into that insurance mechanism. But a lot of conversations and strategies going on to try and lift that pool so that there is increased contributorship. The topic here of sustainable management of these catalytic efforts being described here is clear to us that really governments have to be accountable. They have to offer the fiscal space and discipline required to facilitate and sustain those mechanisms. And so specifically concerning women in our country, I think that we have a lot of challenges, of course, because they've been disadvantaged for a long time and very difficult for them to access really whether it is education or employment or even business opportunities. So our social security system has also transformed and really lifted up the number of beneficiaries in our social cash transfer mechanism, where there is really preferential selection of elderly and disadvantaged women, so they begin to get that social cash transfer incentive. So at a very high level, these are some of the structural and fiscal changes that are going on. But I think within the sort of health space, there are a lot of opportunities, particularly that relate to women. And part of what I described as the sort of constituency funds that are being distributed in all constituencies is a requirement that every health facility must have running water and must have solar-driven lighting, regardless of how remote it is. And I think the very clear instruction that really in the next year or two or so, there must not be health facilities that don't have a maternal sort of room with running water and lighting. But also we are pushing towards making sure there is increased health workforce across the country. Again, in the background I gave, with the same budget that we inherited, we managed to hire 30,000 new health workers that have been deployed by government. Now, that's a drop in the ocean given where we are coming from, but I think a very positive stride demonstrating what is possible when there is political will required to move that agenda. I think I should arrest it here, but there's much we can share around what we are doing in Zambia. Thank you.
Thank you so much. And I see that Jeffrey has joined us, and considering it's so late, if we can try you again.
Thank you. So first, should we test? Can you hear me?
Yes, yes.
I
And
see
if
a
you could go
thumbs
ahead
up.
and-
That's
Yes.
awesome. And of course, I'm going to be in Geneva in just a day, so we'll then hopefully have a chance to see one another in person. So first, I just want to share, thank you all, esteemed colleagues and panelists and all our friends listening. What a wonderful opportunity to be here and share a few words and really listen and learn like all of you. And recognizing now more than ever that we need to work together to identify key solutions and innovations towards a more sustainable and resilient future that's integrated and really builds and strengthens local communities. I'd like to also build upon what we just heard from our esteemed colleague from Zambia, recognizing from the recent spring meetings, IMF, World Bank, that we are dealing with a tightening fiscal space. And we are seeing in some cases where this is restricting or also impacting the resources potentially on a domestic level that could be allocated towards health, but also some of the challenges that might mean for financial flows, particularly private sector financial flows, as we're dealing with higher inflation, and also in countries, particularly sub-Saharan Africa, where debt is and repayment of debt is a challenge. And so for PEPFAR, which, as we know, and I am truly privileged and blessed to be part of, has an incredible and extraordinary success over the last 20 years, where we've had investments of over $120 billion, where we have saved many millions of lives and also improved the lives of many millions, particularly for women, children, and vulnerable populations. And our chief executive, Ambassador John Nkengasong, first ever national from the African continent, has provided a truly extraordinary vision of where PEPFAR and the program, through his 5x3 strategy, is heading towards a more sustainable future. And from my perspective as a Chief Innovation Officer, focusing on our co-investment policy and sustainable health financing for our programs, looking at particularly several areas that we've heard previously. First, looking at efficiency. are the resources there that are in the system being leveraged and aligned as best as possible? Sufficiency in terms of, for example, we know coming up at UNGA in the fall, looking at universal health coverage, are there enough funds within the system itself to support those goals? And equity, are the funds that are there reaching the most vulnerable populations that we need to serve? And then the piece that is really, I think, what we all recognize here around this table in person or virtually are the innovations, whether it's the fintech platforms, e-wallets that empower consumers and demand-driven financing, and new types of, as we've heard from our colleagues from Unitaid, whether it's formulations or diagnostics, and of course, models that look at indemnified or pooling risk in ways that we could also not just look at domestic resources, private resources, but how perhaps some out of pocket for those who can afford and willing to pay will also be able to contribute. And the other things as I wrap up here and turn back over that are so critical, and I think we all recognize, is the most powerful voice in this are the clients and those from the communities we've served and following their journey. And if we're not improving their journey, then we need to realign how we're focusing on these blended financing and other mechanisms. And for example, on a very glass half full note, and again, I share with other colleagues around the table, both physically and virtually, the true transformative power of what we're seeing in some of these platforms, whether it's the e-wallets or fintech, that are really empowering the clients to be able to choose the services that they seek, and also as a means of economic empowerment at what would be the tier 1 or tier 2 in the communities, where through indemnified models, they can actually participate in helping to extend services to their neighbors while also improving their own economic stability. So I'm really looking forward to today's session, learning from some of the case examples, whether they're at the high level, like we just heard from our colleague from Zambia and what they've done with their resources around human resources for health, but also the entrepreneurs and other investors that are looking at these innovations that could be truly game-changing in improving quality of service, yet also extending the capital that is there, catalyzing it, and allowing us to do more with what's in place already. Thank you, and I'm going to turn over and looking forward to hearing from the rest. Thanks so much.
Thank you, Jeffrey, and we look to meet you in person as well when you arrive later in Geneva. I think, the U.S. government has done amazing blended financing, vehicles, some of which CGHD has been part of, and the Girls Education Fund for Africa is a great blended financing vehicle that we've seen be deployed, which really took some of the catalytic capital that, was at the table from USG and really blended it with some of that equity. And so we look forward to continue to work in those blended financing discussions. I'd like to turn it over to our colleagues and Todd from CRDF. I think as you're hearing the conversation, I know that the SCBU has taken consideration of working with partners looking at designing, and as we're looking at scaling different case studies around health, women's economic empowerment. If you could share a little bit about kind of your kind of role and some of the discussions that I know are started around Ghana and sustainability and financing.
Is there a microphone?
Oh, yeah. Here's a mic.
Thank you, Joanna. Todd Spires from, as you heard earlier, before we stopped introductions, from CRDF Global. The program that we are here representing and advocating for and wanting to broaden the aperture of is a program called Sustainable Dialogue for Peaceful Uses, and it is focused on particularly peaceful uses of nuclear technologies, a program funded by the U.S. Department of State out of the International Security and Nonproliferation Bureau, which may seem like an odd place for such a program to reside in, but it is trying to broaden the aperture of nuclear technologies in a way that can bring partners to the table around peaceful uses and non-proliferating uses of nuclear technology. So the goal is to help achieve those UN Sustainable Development Goals. We're really looking at it in 3 strategic ways. We want to grow a bigger table of champions to promote the use of science and technology to achieve those development goals. And really, with all of the types of organizations represented here, partner governments, foundations, research institutions, laboratories, when you start getting down to a more tactical level, but it has to be a public and private sector partnership. And so seeing all of the different stakeholders represented here, that gives us a lot of hope that we're going to be able to broaden the number of people who are advocating for this type of technology. Mobilizing and sort of catalyzing a new understanding and greater acceptance of a full range of nuclear technologies. It can seem like a very large topic. You hear nuclear, you start to wonder, you start talking about cost, you start talking about just the training aspects of that, and then you start thinking about what that actually looks like in practice and how common those technologies are, particularly in the West, but the cost models for a lot of those have come down to the point where they are deployable to least developed countries, to lower income countries that can sustain that basic infrastructure around those things. And then connecting, just bringing people together to understanding where the financing is, understanding where the needs are, and how do you connect those types of things. Ultimately, you can't have a sustainable dialogue about pretty much anything in development without quickly getting to the question of where is the money coming from. And so having this type of a forum to discuss those topics is extremely valuable. Our primary takeaway from this is to understand, particularly for an event we have coming up in Ghana focused on healthcare, the peaceful uses of nuclear technology in the healthcare sector, is to understand what are the needs on the ground. This entire program is designed to be grassroots, locally community-led, so we are not trying to impose a top-down agenda for this. We want to understand what are the needs with partners like you've described from Zambia and the programs that you're working on. How can we help grow, mobilize, and connect the different stakeholders so that we can make a more impactful unit as program. As Dr. Blander said, it is a fiscally tightening environment that we're in, so we have to focus on efficiency and impact for the programming we're doing, and we're looking forward to hearing the case studies that GHD has brought to us and understanding how we can help mobilize the types of funding that you've talked about, Robert, to maximize the impact as broadly as possible. So I'll stop there and turn it back over to you.
Thank you. We've talked about the financing, and for those in the Zoom, I really also want to thank those behind the scenes that you don't see, and some of our women philanthropists for joining us in all time zones. I think a big discussion is metrics, and I'd like to turn over to Dr. Ted. As we're envisioning this, there's a lot of funds being deployed. There's, the gender fund that's been mentioned a couple of times, $15 billion raise, but the metrics, even though they have, measures and evaluation, sometimes those are never met. So if you could kind of guide us through some of how we see structuring some of the metrics around, the development of these sustainable financing models and then case studies.
Well, I think it's important as we talk about how to finance projects and programs, that we also discuss what we would, or what are appropriate metrics for evaluating progress, evaluating success, and how to help countries and people running and organizing programs think about pulling together or strengthening the health data systems and identifying what is important to people on the ground. And certainly we have worked closely with our colleagues at WHO and the WHO kind of cancer research group at IARC. And Maribel, maybe I'll call upon you to just to give your thoughts on how to help our thinking, as well as to what are appropriate metrics for evaluating progress in improving health for women.
So from a research point of view and from an implementation point of view, I think we have some data that we've been using. I am, to start, I'm Maribel Almonte. I am the implementation scientist of the Cervical Cancer Elimination Initiative of the WHO within the Department of Non-Communicable Diseases of the World Health Organization. So I've spent 10 years at IARC working on research for cervical cancer, and I've been part of the initial work for developing the strategy for the elimination. So one of the things that we definitely consider is the data that we have on cancer, of course, and we know that a lot of women die of both breast and cervical cancer, which are the main cancers that actually kill women every single minute that we are speaking now. So basically, I think we had so many ideas over the years because there are several topics that we need to cover. Innovation, I've heard about, you're thinking about models of financing, how we can actually cover different points of health. But innovation also in the source of financing, but also innovations on technology for us are super important. There are still, we do have many tools to actually prevent cancer, but there is still a lot of things that are ongoing. There are many technologies that are on the pipeline that need, some support to be completed and to be delivered, and we need to give the best options for countries to actually be able to deliver simple schemes, for instance, to prevent cervical cancer, like it's been done in Zambia, for instance, and also to start actually giving, to start actually working on breast cancer, on the early diagnosis of breast cancer. That's what we need now. On the other hand, from the implementation point of view, we thought so many times with TED and before with WHO about how can we actually concentrate some funds that can go directly to the countries for this implementation. Now that we have, some tools that we can use and that we can actually deploy, how do we actually manage some sort of sustainable fund that can be like at least the seed fund for countries to start implementing, for instance, the strategy for cervical cancer, the strategy for breast cancer, everything that women really need. And we've heard all morning that women are a large portion of the economy of every single house and of every single country. And they are the ones that actually maintain the family. And when a woman dies, there are a lot of orphans left as well. So I guess this is the point. We wanted to actually, at some point, have a fund that can be managed by, I don't know, WHO, other institutions, whoever could manage to actually give it to countries to start, at least.
Thank you so much. And as you were saying, sustainable financing, one of the things that the center was involved in was designing, with the Islamic Development Bank and the International Atomic Energy Agency, a blended financing fund for women's cancers, we always say something that's very controversial. It's not lack of money, it's how you structure the money. In that case, there were hundreds of millions of dollars of commitment. There wasn't the structure or the mechanism to deploy it. And so I want to remind us as we're online and, taking, I know, people from different fields, from equity that are managing billions of dollars to those who are also implementing programs like yourselves, we are bridging a wide gap of conversation. And I think we can successfully do it because there's a lot of lessons learned that we can stand on those shoulders and move forward. And that's really where I think some of you have committed to go forward in this conversation, but we need the experts like yourselves. We can't continue to create these funds in absence of the experts who can help us to shape them and mold them, because then they create no impact. We have $250 million funds for women's health. Are they creating impact? Ask Annie. I know they're not, right? I'm not going to put you in the hot seat, but I think that there are those that, are looking across, and so this is, I think, the unique perspective that we have here in time as equity, as women philanthropists, as governments, and also as case studies to really work together in deploying the solutions with some of the UN agencies that are looking at these catalytic efforts, and with those in supply chain management. That was the biggest issue during the pandemic. Had we had a fund that could have solved this issue, we wouldn't have been there. We would have had a fund of funds, a private sector mechanism, and a technical assistance mechanism as well to take us forward. And so with that, I really want to get concrete. And I know, Hafsa, you've been thinking about a sustainable financing mechanism and I want to use kind of your intervention to kind of tie it together from the blended financing that we're talking about, a fund of funds of aggregating, to the insurance mechanisms that you've heard the Director General for Zambia talk about, to aggregating that private sector capital. But we do have that end payer that can't pay at the end of the day.
Great, thanks, Joanne. And it's an honor to be here in this room, virtually or physically, with so many people who have their heart in the right place. So thank you for that honor. By introduction, I'm Hafsa Shamsi. I am the country manager for Roche in Pakistan. Roche has been operating in Pakistan for the last 50 odd years, selling cancer treatments and trying over the last 7 years to impact cancer accessibility for the average population. So kind of we understand the ecosystem. Needless to say, it's a country of 220 million people, 50% women, most of them disadvantaged, and women, due to socio-economic, cultural issues, highly disadvantaged, right? So that's where Roche is in Pakistan. Now for myself, my vision really is, I'm born, brought up in Pakistan, I'm a woman from there, and my aim is really to help empower, like many people have been talking about, to empower them to make their health decisions. I won't start on the long story because let me tell you, there are many impediments to it, but that's my vision, right? How do we go forward? So much that has been said resonated with me in this room. So as the local person on ground, for all the initiatives you guys run, let me tell you things like Jasper talked about over-engineering. I really agree with that. It should be simple models, right? Robert, you mentioned, I think, structure with governance, or I think you mentioned multi-stakeholders, right? I think it's really important. You can bring multiple stakeholders to the table with their own expertise and structure something. I think that's really this thing. Then Dr. Jeffrey, I think you made a really good point. How does it reach the right person, right? What's that credible governance mechanism which will ensure the deliverable on your part, that the money comes in and goes to the right place, and the deliverable on my part, that women get treatment? I think so much has resonated. And my one-line answer would be, it is possible. It's really possible. There are enough partnerships and people on ground who can structure it. So that's just the background, and I'll talk about a little bit about what Joanne asked as a question. What am I envisioning? For the last 7 years, we've been helping two-way funding program, Roche and the patient, or Roche and somebody else, some philanthropist who covers the treatment for the woman in case she suffers breast, cervical, or ovarian cancers. the incidence is really high. 50 to 70% is the mortality rate. So it's pretty much a death sentence. Right? How do I want to take it forward? My dream vision that I'm working on is that we create a fund, a woman cancer fund, kind of like a model where the fund comes in through an Islamic, it's called Takaful, insurance system, or the fund also attracts donations. Right? It's a governed fund. Now, how does that work? Under the Islamic system of brotherhood, what happens is the person who's administering the fund takes an X% administration fee. So and of course, under that fund will come cases, because we are partnering, right, for putting value into the fund with fintechs, with a different kind of, and there are a lot of such smaller vehicles in Pakistan. Now, when the money comes into the fund, there will be genuinely some cases of women who will suffer and they will be treated. But whatever is left over then routes to a patient support program that Roche, we have been successfully running, and helps to solve for women cancers. That's kind of like the big picture thing, which really takes into account a lot of things. Multi-stakeholders, blended kind of finance. You're not really looking towards one thing, because I don't think one thing is going to solve for it. So various partnerships with the private sector. So that's kind of the dream.
Thank you so much, and we're hopefully all of us as partners looking to work with you in how you can deploy that, and looking at the financing mechanisms, because I think they are unique in every country.
Yeah, thank you for the comments. Hi, Jeffrey. So I know that it's so early in Washington. You can look at it as a head start on your jet lag here. Okay. I just want to say how much I'm learning from all of you. This journey started for us about a year ago, and the composition of the panel has been changing throughout the year. And if you measure success as are we having the right people at the table, I think we're there. The variety of people, the expertise, and it's really the right people at this point. So thank you, Joanne and Ted, for really incredible work on this. So I think what we bring to this table is a technical expertise. We look at global surgical care at a systems level and work with a number of health ministries in developing national surgical plans. Zambia was the first country our team worked with. It's a national surgical obstetrics and anesthesia plan. And now we've done a number of other national plans in conjunction with the health ministries. What are the things that we ask for? So, how big is the problem, right? What is the burden of unmet surgical needs? And in this room, women's health needs. The obstetrics was an important part, because the number one reason for mothers dying at the time of childbirth is obstructed labor and postpartum hemorrhage, right? So you really need to have surgical care there if you really are interested in reducing the MMR. What is the current capacity to treat in these countries? And then, and the other thing is, how do we treat these conditions that's context-specific, resource-specific? So for instance, where does radiation therapy fit in treatment of some of the surgical conditions? And of course, most important is, how much will this cost, right? So these national surgical plans actually are fully costed. So, and then what data points do we need to make sure that this system of service delivery is able to be monitored and show that the outcome? And what we've seen when we work with a number of countries is how important women's health is in the unmet surgical needs. I mentioned obstetrics, cervical breast cancer, and it's become a place where, this is where our Venn diagrams, with National Cancer Institute and then Joanne. So I did invite a couple of people from the global surgery community, and I want to just turn it over to Dr. Emmanuel Makassa, you could maybe introduce yourself and then give us, we do have a session at the end towards a third session on case studies, but briefly for the benefit of the financing group here, your perspectives, Emmanuel.
Thank you, colleagues. Good morning. So I'm Emmanuel Makassa, as introduced. I lead the SADC, Southern Africa Development Community Regional Collaboration Center, and I also chair the Technical Experts Working Group So the technical experts working group obviously has got state actors and non-state actors in their full definition, which includes private sector. So we provide technical support and policy framework support to the member states or the countries. As you know, countries are very committed to try and improve maternal health as part of the bigger picture. But those political commitments need to be translated into something that actually touches the woman that needs it the most. And so we guide the countries to develop their national surgical obstetric anesthesia plans. They can be called anything else, but basically it's surgical plans, surgical healthcare plans. Now, these plans obviously are policy frameworks that provide space for all the actors to play a role in providing care to those that need it the most. And obviously the governments have to lead because they're the owners of the programs and the people, and they have to make the initial investments. But obviously these plans, like we said, are and usually prioritize maternal health and children's health for obvious reasons. And they are really important because in the past in health, we've mostly invested, we've mostly focused on, public health. And we've always left out the clinical aspect of this, which is really critical. And so, for example, if we apply this to what we do in terms of the policies we create, and I'll give you the example of the Zambian policy that was formulated, I think, from 2017 to 2021 is being revised. The driving force behind that was really the statistics that came out of women's health. As we were getting towards 2015, the assessments of our targets in the Millennium Development Goals on maternal and child health were really, really bad. And one of the key weaknesses we had while we were not meeting those targets, even reducing maternal mortality, for example, was the lack of access to surgical care that are actually required for example, if you want to, issues of cervical cancer, you need to biopsy. If eventually a woman has got cervical cancer, if you're going to think to do anything, have to have a tissue biopsy. Breast cancer is the same story, but the biopsy capacity or technical capacity to do that at the district hospital facility is not there. And so how do you improve that? Because, before you can even talk about the medication you can give them or the radiotherapy or anything that you can do, you need to know that it's actually this particular cancer, and surgery then comes into even that aspect. Around childbirth, mothers usually die because of bleeding. Again, you can't stop bleeding with a paracetamol or a tablet. You have to use some surgical instruments to, whether it's a laceration or a tonic uterus, whatever it is that you want to do, or a hysterectomy, it's a surgical intervention. So these also obviously provide very good entry points, but the governments have to structure. The policy then structures the roles that the government will play, the role that civil society will play, the role that private sector can play, to all of us then co-invest and actually have meaningful impact for the investment that we make. Obviously, these policies also have very good inbuilt monitoring and evaluation systems that can then demonstrate, first of all, monitor the progress of what you're doing, and then, of course, demonstrate the impact of the investment you're making. Impact in what? Well, we have to gather evidence of the impact of how do you strengthen the health system. We believe surgical care systems are cross-cutting. They are not horizontal. They are not disease-specific. They'll have impact across the whole health system, across all levels. And then we also want to see impact on the health outcomes. We want good health outcomes. We want to reduce maternal mortality. We want to reduce infant mortality. That obviously can be impacted. And then, of course, we want to see the socioeconomic impact on the person that's involved, the family, and the community. And it's true that these are very good entry points. Maternal child health are very good entry points because obviously mothers and women drive the economy. Even when children are involved, it's the mother who bears the brunt of having to take care of that child, whether it's congenital abnormalities, whether it's trauma. And so for us, we believe that surgical systems are a very good area to invest. But of course, the investment can only make meaningful impact if it's structured with the country. And the country has to lead to provide that framework, that policy framework, and create the space for the others, non-state actors, private sector to actually invest.
Thank you, Dr. Makasa. And then I know we'll have additional time to discuss case studies in more detail, but I just want to have introduce David Cunningham from KidsOR, who's really, their organization they've really cracked the code on how to build out ORs and keep them sustainable. So David, maybe you can give a glimpse of the work you do and save the bigger talk for later, but it's for the sake of the funders here. Thanks.
Great. Well, thank you so much. Kids Operating Room is a global health charity working in 27 countries. The president of our US 501c3 is Lily Buffett, who some of you will know. But I'm here because we own a company called Global Hospital, and Global Hospital provides specialist engineering solutions. So if you're investing in healthcare, we can make your healthcare investment more efficient, last longer, because we can deploy local engineers. If you're developing surgical systems, we can put solar provision into your operating rooms to make sure that the capacity of that operating room is maximized. So before you start thinking about how do we expand more surgical facilities, we can make your existing facilities work full-time regardless of local power supply. So although I'm here partly with my NGO hat on because we work around the world and trusted by governments from Afghanistan to Zimbabwe, I'm also here because our company, which I think is conscious capitalism at work, has the capacity to support what you're doing and make your projects much more impactful.
Thank you so much. One of the things that we have discussed is the structuring, and I'm going to turn it back to those online before you log off. But you know, when it comes to really unlocking the power of women, I think that's hard. And one of the statistics we hear is that women-led managers tend to do, you know, better than men in their performance metrics. But it's really hard to get those both blended financing vehicles led by women and sometimes get them into the discussions on the structuring and the financial sustainability. So as we're doing it from an Unlocking Eve perspective, you could go a little bit into kind of how you see that women's leadership perspective, because we are talking about women's health and economic empowerment under WEN, and sometimes in the rooms that I enter, I am the only woman at times. Not here, because you know we're talking health, but in the financial discussions. No, you know, I know all the men, and Jasper has heard this many times, but we need more women in those financial structuring discussions, in private equity, in that world of you know, VC as well.
And thank you, Joanne. And as I look around the room and listen to everyone, first of all, there's a good representation of both genders here, but it's not just about women, it's about integrated leaders, leaders who can balance both the feminine and the masculine leadership qualities that are required to actually move from insight to action to outcomes. And I'd like to start just to kind of, you know, with the message from Apollo 13, Houston, we have a problem, got the attention of the world, and more particularly the leaders, the engineers, and the policymakers of NASA. Disaster was averted, and breakthroughs were produced. So we as co-founders of Unlocking Eve, myself and KV Took, we see the possibility of an equally dramatic and life-saving opportunity right now for healthcare by unlocking women. Now, saying this is speaking to the converted, because everyone in this room probably feels the same. We talked about technical, you know, the engineers, we talked about leaders, we talked about finance, we talked about policymakers. But until we are really in our hearts of hearts, this convinced that Houston, we have a problem, nothing seems to be moving. So Kay and I have been executives in the healthcare space for 25 years combined. We've lived and worked in 10 different countries, and we're very motivated during the pandemic to see that countries led by integrated leaders, many of them women, had 6 times less deaths due to COVID-19 than countries not led by these type of leaders early on in the pandemic, later on equalized. And so we're very motivated by 2 goals. One, which is how do we increase the number of women in decision-making roles in healthcare? As we know, women represent 75% of healthcare decision-making, 75% of the workforce. So we're working with the WHO on a very particular project. Vesna Petric, the chair, is actually very involved to talk about if we're going to move to implementation, because that's what we're really talking about, is implementation of these things. This is the hardest thing to implement. We're going to have to involve the constituents, which are women. 75% of them are going to have to be part of these implementation plans. So they need to be at the table in the decision-making roles. And the second goal is how do we unlock, once women and men the people with their head and the heart in the right place are at the table. How do we ensure that they have the leadership skills, capabilities, and the how do they structure these things so that we actually get impact? So those are our two goals, and our aim is to unlock 100 million leaders by 2030 to advance the Sustainability Development Goals, SDG 3 and 5. And so what we're looking for is partners, right? Because we're here to bring those two goals and obviously our huge network of partners that we've collected over the 25 years we've been in healthcare. But we're looking for partners to and case studies. We're piloting in 8 countries this year. We're going to be in South Africa June 2nd and 3rd. We'll be in Asia at the end of the year, and we're working with GHD on a really important roundtable at the UNGA in the fall. So that's our goal and that's our aim, is to really put this from insight to action. We have a lot of research projects as well and pilot projects, which I've already taken many names, which I'll follow up with. But that's all I wanted to say about the importance of leadership in that space.
Thank you, and I did think it was very transformative. Some of the sessions you had in Davos where they were mostly women, and to be at the World Economic Forum and having mostly women is quite a change for having been my 12th Davos, and it's usually all men. So not anything against my male colleagues, but it is empowering what you're doing, so thank you.
I'd like to invite our colleague from UNAIDS to comment on your thoughts on how to build partnership and how to achieve good things for people around the world.
Good morning, everyone. My name is Mulea Mwananyanda, and I'm from UNAIDS. I'm based here in Geneva. I'm really happy to be here and to meet all of you and just to get to learn about the stuff that you're doing and are working towards. Really great to know that this is a values-based team and that we all have shared values. As some of you might know, we're working on a new strategy which runs until 2026, and part of that strategy really is looking at inequalities and how they impact particularly the very, very last, the people on the periphery. And usually the people on the periphery will be women and children. And therefore, we're really looking to strengthen our partnerships in those areas and to work with like-minded people around advancing health, holistic health for women, and looking at it from a really inequalities lens and looking at the root cause issues that lead to where we are at. Listening to Hafsa from Pakistan, it really resonated what you were saying around the fact that 50% of the population is usually women in most of the countries that we work in. And for UNAIDS, it's also that the majority of the countries that are highly impacted by HIV and AIDS are also some of the most, the poorest countries in the world. So how do we get to a point where we are addressing those inequalities that lead to certain outcomes? So really looking forward to learning from colleagues around the table around how we can put our heads together and look at how we support certain initiatives, be they government initiatives around treating AIDS, because actually treating AIDS is something that is something you can foresee. So it's something that's going to happen now. It could happen in the next 7 years, where people actually access treatment to HIV in hard to reach places. So when you're thinking about models for funding, it's also important to really look at how healthier populations are good for the things that we want to see. They're good for a clean climate. They're good for a just world. So really looking forward to learning more here. Thank you.
Thank you so much. And I just would like to go back to Jasper, John, also Annie and Robert really quick. I know that, your equity investors or development finance investors, you've built different structures. You've heard from the participants around the table. I am going to go in the order of Robert, Jasper, John, and then Annie, because Annie started first when we started a discussion and really opened up in terms of that type of gender lens investing. How can you work with us in structuring this vehicle? How can we make it sustainable, but how can we aggregate the capital? Because many of you, we've had conversations both publicly and privately. It will need a technical assistance arm. You know, it could be a private-to-private vehicle with the expertise of the government surrounding that technical assistance. You have sheets. It could be a blend of both, where you're investing unilaterally in the countries in different blended financing, structures as Hafsa described, or as have been, already implemented in Zambia. You could work directly with the companies, and we haven't had a chance for the CEO of Drugstock to speak yet. But some of these companies have also innovative solutions for how to deploy the end-to-end care for women's health. So, Robert, I'm going to challenge you. How can we do this? And then I'll go to Jasper, John, and Annie. And Jeff, I don't mean to leave you out, so please jump in.
Okay, I know you're looking at me for.
Oh, there's a mic here.
So I know you're looking at me coming up with some magical solution on how to structure this and make it all work for everyone. But, as I hear everyone go around the table, what's helpful for me is to understand why structuring is important. And so, I've been structuring vehicles, and it's easy to do. I've been for about a decade now. But let me give you just, if I can, a real-time example here of what we're working on. And Lars is here from Pristem. He's the CEO of Pristem, which is a Swiss stock corporation headquartered in Lausanne, Switzerland, that is building vertical diagnostic centers. And in those centers, there's X-ray machines that are going to be distributed throughout Africa starting in September. And my interest in coming to the table is that I learned that there are populations of 1 million people that don't have access to X-ray, and they are living with breast cancer, TB, undetected, right? So me as a civilian, as a citizen, as a human being with a heart, I want to do something about that, and they need 30 million, right, to carry out their good work. So my investment hat goes on. I say, okay, we're going to bring in the investment team and diligence this opportunity, and we're going to do it in this kind of financial structure. 15 million first tranche, 15 million the second tranche, easy to do. Then we think about if that is conscious capital putting the entire 30 million in, well, sure, that's something that we could do, but maybe it makes sense to reduce that amount and bring in strategic investors that can help to make that investment even more successful, more impactful, generating a greater financial return for investors. And maybe that would involve, talking to someone like yourself. You might have some ideas. And so we build the syndicate, and those investors that are coming to the table are looking for really impact beyond financial return, right? So as Conscious Capital, the way in which we're structured, we'll take 10% of our profits and donate them to mission-aligned nonprofits, and that's just how we operate.
And just to quickly note, not a lot of private equity does that, so.
No. That would be nice if it changed, but that's just what we do. So at any rate, we may meet some philanthropists who also care about this issue. They want to see X-rays being delivered throughout Africa. So then our unique structure at Conscious Capital is then we say, okay, well, how do we get that grant capital into a company like Pristem, right, which is looking for investors? So we can take it into our public benefit corporation, we can push it down to our C Corp, which is a holdings company, and then push it down to another investment vehicle that invests alongside our for-profit. So that is just structuring, but at the end of the day, it's like, there's people here who need an X-ray. PRISM is here to solve it. They need money, there's investors and philanthropists. Ultimately, like, we're just thinking, how do we get this to here, right? It's like there's a fire burning, how do we move the ocean to here, instead of us at Conscious Capital thinking, well, here's our tin cup, we make money here, we don't here. Yeah, we have to operate in this way. We have to serve our investors and our philanthropists, but ultimately, how do we make it all work to solve the problem? So when I think about this question that you've asked and like structuring and how do we make it work, what I need to understand from the people in the room is that why is structuring it with these groups so important? How does it ultimately result in governments and investors and corporations working together to solve the problem? Now, that helps me. So I'm learning here just as much as everyone else. And when we invest in a company like Prism, and whether we'd invest in another company, we want to understand what are the risks that we don't know that we should know, right? Like, and who can help us to mitigate those risks, right? Because we may be well-intentioned, say we're going to invest in Prism and it's going to provide X-rays, but how can governments, how can corporations help us to have Prism reach more people and distribute throughout Africa? And then, so once we understand that, once we see that, once, at least for me, if I see that puzzle coming together, what are the missing pieces, then I can say, okay, here's how I think we should structure that.
And I think it helps because I think these conversations are important. Some of the paper that you see before you is funds that shall go unnamed that have been created, but in absence of the intelligence of, you know, what is needed on the ground, because they're mainly created from an equity perspective, with, you know, donors coming in and realizing that they have to de-risk it or else, you know, some of these companies won't go into the market. But that's not enough sometimes because these funds have been market failures. And so, Jasper, I know that you've done different blended financing. If you could also address the question to help us.
Thank you, Joanne. I think from my angle, apologize for being somewhat general in my response, but I want to highlight a couple of components that come to mind about, based on the discussion we're having this morning and Joanne's side discussions we've had already on your ambition. So for me, I would start at the horizon and then work back in 3 steps. Yeah, so for me, the discussion is what solution do we want in place and how does money get into the system? So for me, that's always the first discussion. It's not so much, because we work early stage, it's not so much about the feasibility or the first stage rollout. It really is, okay, what do we want to get to? Yeah. And if we then understand how we get more money into the system, whether it's from governments, from donors, from investors, from the National Health Insurance Fund, whatever kind of solution we seek to bring more money into the system, you know, then the question is, okay, but before that money comes into the system, what proof points do they need? And then we talk feasibility, then we talk initial rollout, we talk, you know, the phase prior to that, where we normally are active in with my business development mandate. And then if we look at that, we basically say, okay, what do they need to see? And then if you talk about what they need to see, I'm really talking about business models. I'm not talking about technical solutions. The technical solutions need to be proven. And I'm talking now from our perspective. But we want technical readiness level 7 at least. Yeah, if we put solutions in place, because don't complicate a new approach or a new model with also new technical solutions. Yeah, because I mean, we talked about over-engineering already before, and indeed we have to try to make it as simple as possible because we won't be able to keep it simple anyway. So at least we want to have as low as possible, at least technical challenges on individual solutions. And then the third step, working back, is then the TA to really define the scope of works for the feasibility and make sure that everybody agrees and signs up to what success looks like. And so what's the success at the end of the feasibility that will entice the various parties to commit to the overall structure we have in mind, which would bring us to the horizon in the end. So working back, you know, what's the big picture, and finding out what, with money coming in, what you need as proof points to actually get that money to commit. or qualify for the funds if you talk about a national insurance scheme or things like that. Work back from that and basically then provide those proof points, and before that you will need some TA or making sure that the approach in the second phase is the correct one. So those are my thoughts for now, Joanne. Thank you.
Thank you, Jasper. And a little bit of what I'm hearing is some sort of TA card along a PE fund or blended financing fund. John?
Yeah, I guess I would just build on Jasper's comments. And I think, when we bring together so many different constituents with different objectives and outcomes from an economic standpoint, clearly there is certain capital that's looking for a return, other capital is expecting to be catalytic. And so developing that structure in a way that the waterfall approach meets each of the expectations of those prospective investors, I think is what really brings it all to the forefront. So alignment of interests and their expectations is critical to the success and the raising of the capital, and then turning around and the rapid deployment of the capital in a structure that makes sense. So I think understanding the needs of everyone around the table, understanding their expectations, and how that capital is going to be used and when it comes back and in what form. So, I think making sure we understand that is critical to the success of a timely deployment of that capital.
Thank you, John. And John, Jasper, and Robert, hopefully we count on you as we continue to structure some of the capital there and to come. Annie?
Okay. So maybe pulling on a few strings, I know you asked me to talk a bit about this structure. When I think about structuring this type of facility, I think of the whole ecosystem. You need new technologies. So when I was hearing about your X-ray, I was just thinking of a company in Canada that we've been working with that has the latest X-ray technology, and it basically brings an X-ray to nearly the level of a CT scan in terms of diagnostics. And so that's kind of our role. We fund these types of tools. And then we have other investors that are more private equity investors that focus on the service providers, or the philanthropic side can focus on funding the NGOs or assisting governments with paying as well. And then you've got the infrastructure, whether you think of the power or the telco infrastructure, that's quite critical. And within that, you have another tech angle to provide the newest and latest solar technologies or transmitters or whatnot that my former life. And so when you think of structuring vehicles to really empower women's health, I think you have to really think flexibly around all these needs and being able to create the right risk return framework within the structure. And I think I saw the chart that you mentioned is quite interesting, because a lot of groups here, you're focusing on the equity, the first loss, and the debt, and the guarantee. And those are all the key pillars. And what I like about the structure you've provided is that it does really allow a lot of different funders to be involved with their own risk-reward appetite. And I do think it's quite interesting in this framework. And I'm not sure what comes next, but certainly I'm interested in moving the discussion towards the structure itself.
Great. Well, we'll follow up with the structuring specific with some of you just on equity investors and our women philanthropists also on the different waterfall capitals that we need. One of the things, Jeffrey, I don't know if you want to comment anything as well.
Thanks, and I'm going to do another test. Can you hear me okay? Yeah. Awesome. Thank you so much. First of all, just a brilliant question, and Robert and other panelists for kicking us off. And really just a couple thoughts to further frame. From the seat and office that I've been in, I've had the real privilege of interfacing and having discussions with different groups, whether it could be private equity or venture capital, and then of course the more traditional development partner. And each has their own metrics of what they may be looking at, whether it's a looking at some sort of financial return, or again, as mentioned from our office, that return has been traditionally the impact. And one piece I just put out there is also appreciating that we also may need to consider how we look at traditional metrics and how we look at traditionally we may be investing. And I'll give it a classic example of having a discussion fairly recently with a venture fund that's been looking to put investment into the African continent around private health sector and SMEs, and also some of how they reach into the very populations and concerns we're talking about, women's health, new technologies. And from their perspective, looking at, for example, a portfolio and what is the risk? And for example, in a network of thousands of clinics or hospitals, looking at what potentially may be the default rate for those who may be getting loans or other sorts of liquidity to support their financing and their operations. And so if they see, for example, I don't want to, be stereotypical about what metrics may be for different types of funds, but if it's something that could be a default of 10, 15, even 20%, these are the sorts of numbers that are on the balance sheets that, quite frankly, will not get the traditional investments. And I share this because, from our perspective, or for those who are looking at impact, what's a very interesting model that we see is that, yes, there may be X% default, but then looking at that significant number of clinics or hospitals or facilities that actually are not. And so the idea of the blend, or the vision of the blend, I think is illustrated there. And we've heard guarantees and risks, and this is how we work together, where perhaps we can redefine some of the metrics on return in how we use this layer cake approach, so that, again, the numbers that traditionally would have private sector or venture backed concerns who won't be making an investment, how we truly can work together in ways that when we pull our resources together, those risks do become mitigated, and that we really can make these significant game-changing investments in technologies and new models for delivery of care. Thank you.
Thank you so much. And I think we've seen some of those successful blended financing in Power Africa, which I think was a great USG initiative. I'd like to turn it over to the CEO from Drugstock, because you are a company who is looking at that eco chain. We've discussed supply chain. You need support both from kind of a technical assistance perspective in deploying the supply chain, but you're also dealing with investors on the ground. So you're one of those perfect examples of how do we do this, right? You are providing drugs to the last mile, but at the same time, you have consumers that can't pay, you have consumers that pay, and you are also accountable to investors.
Thank you, Joanne. My name is Chibuzo Opara, CEO of Drugstock. So my background is medical doctor and finance. And Drugstock is a tech-enabled pharma distribution platform that democratizes access to good quality pharmaceutical products for hospitals, pharmacies, and patients in sub-Saharan Africa. Last year, we did 30 million prescriptions and to different players across the space. And one of the interesting things that, first of all, I'm really excited to be here and listen to this kind of conversation happening, because typically when you work in the field, you sort of are agnostic to these levels of conversations happening, and just hearing that, people are thinking a bit further than the traditional ways that finance, comes together at that space is quite interesting. We're venture-backed. And so I'm very used to having conversations about IRR and things like that. But at the same time, I speak a lot to people in the healthcare space who, for them, impact means something else.
So it's always very exciting to see when you have both conversations in one room, and everybody's talking about, the same thing. For us, one of the things that we quickly found out when we started to work using tech to deliver pharmaceuticals to the last mile was that, like Joanne mentioned, there's a lot of challenge with affordability and all that, and financial institutions could not grapple with how you would extend credit to that space. And, to the credit of the space, one thing we found is that defaults have been extremely low because for a lot of people, healthcare institutions operate on the basis of trust among professionals and things like that. And we quickly found out that there was a challenge with financing, with inventory financing and financing that space. And we came up with an embedded finance solution along with what we were doing. And the interesting part of what we did was not so much that we brought any new finance into the space. It was just about how we brought it. So one of the things we did was to tokenize payments. Instead of doing like a large sum of payment, you would do a drip type of payment. You would connect different levels of the financial system down into the space, like using people's phones, wallets, things like that. And so you could make capital really accessible at the last mile for people to access products, because these monies we're talking about are unit dollars and things like that. But if the velocity of the money is not moving enough, then you don't have that value captured in the space, right? You might have something that money is pushed down and it stays for a long time, and then it disappears, it evaporates. And we're looking to now expand that to consumers and to patients. We've been thinking about that and some of the ideas, and I'm excited to have a lot more partners jump on board with that. For us, we're a private sector company, but obviously the idea is bigger than us. We're looking at taking this way beyond what we're doing now. And I think that, for a lot of people, financial access for healthcare, especially vulnerable groups, women, children, financial access is not just about the quantum, it's also about how we deploy it. It's about, the partnerships that are structured, the governance that sort of encapsulates how that process goes, and obviously what metrics we set about how we're making an impact in that space, because impact means different things to different people, even in this room. And so far I think our investors have been happy and our healthcare partners have also been happy. And I think it's something that we would like to keep driving. Thank you.
Thank you. And before we take a short coffee break, I just wanted to turn it to Faustin real quick on the supply chain. Our colleague here from Drugstock talked about, the company perspective. I think a little bit in the unique role, as we heard earlier from the Director General of Zambia, is you need the country approach. And so as we're creating this, and you could create a fund in a typical blended financing manner, which we've done with other governments, and in absence of these conversations, or you could do it with the help of both the finance and the health ministers. And I really challenge you to maybe work with this group, because you already have the ears of the health ministers. Can we get the ears of the finance ministers and look at some of these catalytic sort of financing vehicles? But over to you.
Yeah, that's interesting. As I said at the beginning, we are supporting 14 countries, Africa Resource Centers, but we also support the regional economic communities like COMESA as well as WAHU, so that we can, from there, benefit all the member states of this organization. And as a technical advisor to government, we are actually a trusted partner. And we live firsthand the challenges that governments have on the continent of juggling around different and many priorities. So you rightly say the Minister of Health might have all the good ideas that we're talking about here, X-ray, scanners and things like that. But the Minister of Health still have to convince the national governments to have these things put into the national budgets. and get some part of that budget from the finance minister. And most of the time, they juggle, as I was saying, between different priorities. What we're witnessing is that as much as innovative ideas can come and support, we need to make sure that in those priorities of the Ministry of Health, supply chain is strong and resilient, not the supply chain for like COVID situation or all these emergencies, but a regular supply chain. And as the word says, a chain. So we should be talking about the procurement, the storage, as well as the distribution to that last mile that the colleague was talking about just now, so that the product can get there. So if we don't have a strong, resilient supply chain, all these nice ideas and blending financing to come in, it's not gonna give the result that we are expecting. So investing first in supporting the Ministry of Health in these countries to develop a strong supply chain, going from pool procurement maybe to delivery will be a starting point in my views, so that we can see what innovative ideas and what innovative financing can be brought in. One country might not be able to buy into the idea despite the fact that it has been financed because it's just too small and too difficult to implement into their supply chain. But a group of countries can come together and procure these new ideas, and the blending financing that we're talking about here can be done at that scale. So that's what we're witnessing in the field. Thank you.
Thank you so much. We're going to take a very short coffee break because I know there's a lot of you online besides just Jasper, Jeff, and John. And so, yeah, we have it's closed virtually, but we do have some of our women philanthropists on the phone. And so if we're going to take a quick coffee break, so don't leave us. And then we'll be right back to discuss some of the case studies in more detail so we can move them forward. I'd like to turn it over to Dr. Ted and Dr. Key to take us more into some of those case studies and deep dive. And we will go back to the financial structure, but I want to give a chance to those case studies to get more concrete, because I know that we have several people who want to share some of their thinking around that deployment of end-to-end care. Yeah.
Oh, that's case study. Okay. So we wanted to also, I mean, this came up in the prior discussion, was the potential role for both universal health care as well as more limited insurance schemes to help support part of the diagnosis and treatment of women's cancer and conditions affecting women. So I guess maybe we could start with Maribel and Philippe, some of your, I know you all have done some evaluation or have looked at globally the kind of where universal health care stands across countries in terms of covering cancer diagnosis and treatment. Could you comment on what the observations have been?
So I will pass through the statistics to Philippe, but I have to say that although universal health coverage is one of the key flagships of WHO, in many countries this is far away from what we want with respect to cancer in particular. So in some countries, we can have the diagnostics or the tools to prevent cancer being covered, and then once a woman is diagnosed, even with a pre-cancer, she may not have the coverage to go on to the treatment. This is if it is already there. There are other countries that cover all that part, but once a cancer, an invasive cancer, is diagnosed, there are certain parts that are covered, and there are other parts of the treatment that are not covered. So I think we are still far from having a free service for cancer diagnostics and treatment. So I don't know, Philip, if you want to add something on that?
Hi everyone, my name is Philip Mehus. I'm an economist in the Hi everyone. So my name is Philip Mehus. I'm an economist in the Economic Evaluation and Analysis Unit at WHO. Just to give you a little bit of my background to understand as well where I'm coming from and what my expertise is, I'm certainly not a financing expert. Blended finance is also one of the first times I'm exposed to the topic. I know the theoretical basis of it, of course. So in our unit, we work primarily on priority setting and health technology assessment. So basically how to identify which services should be included in benefit packages within low and middle income countries in the context of UHC. So we provide primarily country support to member states in developing institutionalized health technology assessment systems whereby the decision-making process is embedded within country-level structures. So yes, as Maribel said, so there has been a survey that has been conducted on the availability of cancer services. If I hadn't known the question on beforehand, I would have popped up some data and prepared a little bit better of it because it's the cancer team who actually did the survey. But as Maribel says, it's true that while diagnosis has a relatively good or bad, whatever perspective you have in terms of coverage, it's actually the treatment which is very low within countries. So while you have diagnosis, you don't have treatment actually afterwards. I think one of the main challenges that we've seen is primarily related to human resources and the current capacity within these countries in terms of the available human resources to actually do, in the case of cancer, to do the diagnostic workup as well as to provide treatment services. And that's why I was. I mean, we had a very good comment just before the break from our colleague on the supply chains and the strengthening the procurement systems as well. I think it's the same for a lot of the basic building blocks within health systems in low and middle income countries is that there's still a lot of work to be done with that respect, both in terms of the health management information system, but I think primarily the survey has shown that the human resource availability and capacity is very limited to actually implement very advanced, that doesn't mean that it cannot be done, of course, but the availability is very limited at this stage. So yeah, that's a little bit from my side.
Thank you so much. And with that, I'd like to welcome Your Excellency, Dr. Zainab, and we are pleased that you've joined us. And we've started the discussion in the morning on structuring a blended financing vehicle. Now we've moved on to insurance, and I think it's so timely that you're here because you are looking at some of those innovative financing mechanisms to deploy in Nigeria, specifically around women's cancers and finding those sustainable financing solutions for Nigeria. So if you could, to give you a way of background, we have some of the development finance institutions that are listening to us virtually, and then also some of our women philanthropists, in addition to the people here at the table. So, Your Excellency, if you could talk a little bit to that mechanism, it would be great.
Hi, good morning, everyone. It's a pleasure to be here. Like Joanne said, my name is Zainab Shinkafi Babudu. I have a health background. I'm a pediatrician, but I ventured into politics by association because my husband is the governor of one of the states in Nigeria. Nigeria is one of the largest countries, or is the largest country in Africa, and even the most populous black nation on earth. Our current population stands at about 230 million people. Now, when it comes to cancer control, we have on record from the 2020 Global Cancer Statistics a new diagnosis of 120,000 per annum. We know that this is grossly underestimated, and burden of cancer as well as other non-communicable diseases is constantly on the increase. This you all know. But for a country that has many problems, financing is not always efficiently managed, as indeed programs. The political instability, there's a lot of insecurity and some difficult to navigate terrain. It's hard to deploy the solutions. In comes universal health finance coverage that gives us an opportunity to bring the women under an umbrella that can help to improve their care. I didn't mention things like awareness and low education, which we also know about. So in Kebbi State, we've been able to achieve a little bit more than other states, I think, because of the political will, the push, and the ability to partner with various organizations, both in government and out of government. And this is the answer for most African countries, and definitely for Nigeria. There is a narrative of government doing it on their own, but it has to be in partnership with the private sector, with civil society, and of course global organizations. The health insurance in the state health insurance was started about 3 years ago, and only recently have formal sector deductions begun. One of the innovative ways that we have worked with it's called the KECHEMA, Kebbi State Contributory Health Insurance Agency. We have been able to lobby and negotiate. It helps when you're the wife of the governor interested in cancer, I admit, to have 5% of the formal sector deductions to cancer control. We started a cancer control plan in 2020, and this is coming to the end of the first 3 years this year. And funding it is going to be a problem if we don't have a sustained inflow of funds. It covers things that I spoke about: awareness, diagnosis, treatment, palliative care. So with that inflow of funding, we have been able to secure something that will go towards the spectrum of cancer care. Now, in the past, we've also reached out to government, of course, and other high net worth individuals within the state to set up an indigent cancer fund, which has been greatly beneficial. As a country, Nigeria also has a cancer health fund that is currently ongoing, which the federal government commits funds to every year, and is managed by a committee that I also sit on, and goes to the 7 pioneer teaching hospitals covering 4 cancers now: breast, prostate, cervical, and of late we were able to add childhood cancers. So I guess the lesson is just about partnerships, about speaking out and telling the story as it needs to be told. In Africa, we say if a tree falls in the forest and nobody hears about it, did it really fall? So we need to tell our stories, we need to tell our strong stories, and this is what I try to do. It's by no means the final solution, or we're not at the end of it yet, but we're starting and we're getting somewhere. So with partners, philanthropists, global partners, pharmaceuticals in particular, we've done a lot of work with Roche. We've been able to achieve something, and so my message would be, let's keep up the sustainable financing, let's keep up the partnerships so that we can improve the cancers that are affecting our women. Thank you very much.
Thank you so much, Your Excellency. And you've been at several of the WEN meetings, and really, during the Africa U.S. Summit. And I think, as we move forward with the different partners, really in terms of the deployment of the case studies, we look forward to working closely with you. I'd like to turn it over to Dr. Key.
Yeah, thank you. Thank you, Your Excellency. I had no idea you're a pediatrician. Yes, talking about insurance, how do we pay for the services that are so critically needed? And there's this idea that, 2 myths. One is we're not looking for a free healthcare service. People say universal health coverage, universal health care. People pay for food, shelter, education, and healthcare as well. To put things in perspective, annually, $10 trillion a year is spent on healthcare. People are paying for this. And about 60, now granted, a big portion of that is US, but overall globally, $10 trillion. Of that, 60% on average is government spending. And this is great. We want to actually see an increased spending by government because typically that helps the poorest. But the other 40% is private. It's money that people are spending, $4 trillion a year. Half of that is for out-of-pocket expenses, so per transaction. But the other half, $2 trillion, is spent buying private health insurance. Now, we all know that when people typically spend money on healthcare, that really the ones with the money are the ones that can access it. So it's not a very equitable system. So can we look at a business model that clearly there's people spending money and rechannel this private money into a system that is able to deliver more equitable care, especially in the context of women's health. So that's sort of setting the stage. I have one example I want to bring up. So I know the Zambian people, the representatives are here, and Mikasa, Dr. Mikasa had to step out for a little bit. But one of the things that we've been talking about is the fact that the formal sector, there's been an increase in the social health insurance scheme, and they're expanding that. My understanding is that the social sector, the formal sector health insurance now covers certain surgical services. That's a great news, but one of the other piece of information is that there's actually the capacity to deliver these services when needed is limited. So you've got a strategic funder, and you've got the need, but you don't have the sort of the factory, right, the delivery service to provide this. I wonder, this is kind of situation where investors, private equity, government can do a blended financing to build out these facilities so that at the end of the day, the outcome, right, the people who need these surgical operations can access that. Maybe I'll go to Professor Chilenge, for your comments on this.
Thank you very much. Indeed, the overriding approach is to drive the agenda for universal health coverage. And I think that the aspects of interest to this conversation, which is, some of the causes of women death, with the technology and resources and knowledge currently available in the world, those can be dealt with. There are particular cancers and difficult conditions for which we, as a medical fraternity right now, may not have solutions for. But there are things for which solutions do exist. And so from the government sort of policy framework is to make sure that you avail access to health care to as many people as possible, and insurance is one mechanism. Now, I alluded to the fact that the health insurance scheme as we have it, it's just born now, and we're trying to push it further. But the challenge has been that it is insufficient. The models suggest that for a population of almost 20 million, you do need 4 to 5 million direct contributors in order to meaningfully cover everybody. Unfortunately, the fraction of meaningful contributors is obviously much lower, and there is a gap there. Something else that the government has done, which I didn't get an opportunity to share, is actually just last week, the minister was signing a statutory instrument that requires that from that the collections of the health insurance scheme, there's a specific drug fund. And in that drug fund, it's also an open basket that can go to support further commodities that may be lacking in the interest of providing general care. But the key issue really for surgical interventions is that we've got to make sure that the basic surgeries that that for which the techniques have been known for years, that those are available to the people when they need them. And the issue of women bleeding to death during labor, I think that there is enough knowledge to stop that. What we do need to manage is a frame where colleagues like Dr. Makasa work through the processes and procedures to guide the colleagues more in the grassroots level. And we also have an investment into telemedicine facilities now that surgeries in the more peripheral places can be supported remotely or even physically by having experts move in for the elective one, the things that are planned, move in and support them on the ground to do that. But key is the sustainability question, the structure that the government makes sure there are people who are being trained constantly to take up that responsibility in the districts and the more remote places, so that these procedures, to the extent possible, are domesticated. And then you only leave the more technical and more maybe complicated surgeries to move upwards to the tertiary facilities where you have the Makasas and them to handle. But I think that we need sort of a structured frame in which basic life-saving surgeries can be facilitated countrywide. And I think that is possible. And I think that it can be conceived in a way that you begin maybe with several districts or a couple of provinces and other districts in there, and pilot it, learn lessons from there, and see how you scale it up. But I think that in a reasonably short period, you can have a concept proved very successfully and really have a model that perhaps can be scaled up and other countries learn from. Let me end here. Thank you.
Thank you so much. I think maybe if we look at the catalytic capital, I know some of you have the diagrams, and Jasper, I'm just showing catalytic capital, blended financing that you're very familiar with. So, but for those in the audience that's not, as you were speaking, one of the things that comes to mind when you were talking about the tertiary, the Mikasa, and also the capital that's needed, because people can afford different types of care, is maybe as a group, we also look at a case study in Zambia, matching the types of capital that are available at the different, district hospitals, depending on the payer, right, and the user, and how that can be deployed in conjunction with, Harvard that has the technical expertise, and, Dr. Ted that has the USNCI. But it seems like it's different types of capital for different types of structure, and looking at that as a case study, if we can work with you at that. And I want to turn it over back to Hafsa in terms of the insurance discussion. You started our previous session on that financial sustainability and kind of went into that. And now that you've heard more of the discussion and you've heard, comments from Director General for Zambia, is how do you see kind of those challenges in the insurance and successes of how the partners can work to try to help scale some of the initiatives around insurance mechanisms that you're looking at in Pakistan?
Yeah, so the way I see it is universal health coverage by itself in countries like Africa or in Asia is really sectored around primary health care for the most part, right? And it's a government initiative. So my view is that we have to stay outside of that space, right? Kind of take it into private partnerships that eventually can scale into the universal health coverage increasing, right? Because when I look at like a country like Pakistan, 220 million people, yes, they are covered, 40% below the poverty line. So my universal health coverage is really looking at things like child mortality, it's looking like polio, and it would be similar for countries in Africa, right? So the demand the fiscal space to really go into stuff like cancer or tertiary care is limited. Hence, I kind of am staying away from that kind of thing. I'm really tilting towards private partnerships. And I mentioned earlier, I'm really looking at, say, what if we make a fund that's specific for women cancers, right? What if various parties can come, stakeholders can come onto the table with their own technical expertise? So it would be people, say, in the diagnostic space, say in awareness space, and we can cover the journey to bring it to that place where they can get, they are aware, they are diagnosed, which is a big challenge in countries like us, and then get treatment. Now imagine a world where that happens for, say, the next 5 years. Of course, it will help mature the systems. The universal health coverage in every country will mature in those 5 years, and they can lead to multiple partnerships, etc. So this is how I envision it, because I see the reality on ground for primary and universal health coverage is also very severe, right? So they're also tackling many issues. DHQs at the district hospitals, what's the capacity for screening? Right? Imagine if we can intervene and kind of simultaneously run a private diagnostics section, similar to what you were mentioning. If we can do that, eventually I don't see a problem at all with it getting kind of blend together with the public-private and turn into a public-private. But for the short term, I see mostly really in the private space. And that's my personal thing.
May I make an intervention on that? I hear what you're saying, and I think it makes perfect sense. The challenge we have in Zambia, though, is that the health system, as it happens, we have private sector addressing the needs of a very specific audience in the very urban areas, and in which case the issues we are talking here about women dying in child labor, that happens in a space where there isn't private practice. And I think that may be the slight challenge to the model for us in Zambia, because in the rural areas, there isn't private practice. So it becomes very difficult, to implement a model like that to reach the vast majority of the people who really need that care. The ones in our urban centers, it's important, they do have needs, but for our primary care, the very basics of things which people should not die from, those are largely in the deprived rural places, and I think we need solutions that will get to that last mile.
Yeah, and just one sentence on it. Yes, in Pakistan, the same problem. So what we've done is kind of liaise with the social enterprise that has clinics, small clinics around the country to help address this, because the urban and peri-urban slums aren't that big an issue. It's this, when you go into districts where it takes them 18 hours to even get to a tertiary care hospital. So we've addressed it through social enterprise partnership at the moment.
Great. I think one of the things is, we're getting a little bit deeper, but we do want to look at each case study. And also, Jasper, I know that you've done some work in Pakistan, and I know also that, just looking broadly across primary healthcare, kind of that affordability. I don't know if you care to comment some of the de-risking tools that could be available as we look at these different mechanisms.
Yeah, thank you. One of the things we looked at, and we did a fair amount of work in Kenya. And one of the reasons we did Kenya was two reasons. One, there's a paying middle class. So it usually means that a lot of solutions are available in country. And the second thing was that there was a national hospital, actually, insurance fund, as it's called. So there's a national insurer that already has money available for the system. So that was definitely one very helpful one. The other thing is that on the affordability, as said, our main lesson was not to over-engineer, because there we definitely found that we had actually gone wrong there in the Makwene case that we did with NGO and OEM. So that definitely came into play for us. The other thing is on the affordability, we really forced ourselves to start small. And only by starting small is really the capital that you have to raise is less, even though from a scaling perspective, the opportunities are there, but the road is just a little bit longer. So that's one of the things that we did, even though from our perspective, it takes a lot of time and effort to properly start small because a lot of upfront costs you have anyways. But that was definitely for us in a situation where there really was not much. That definitely was the approach that we took. And then it depends on the kind of parties that get involved. And I said that definitely the combination of public and private was very appealing to us. Also ensuring that when you go to the more underserved areas, as was also just mentioned, that you really also want a commitment from the government, and that is something that they want you to go to, and that they want to support you there. And there are financial commitments from the government, the financial support from the government was very helpful.
That's really important to know, and I think one of the things is we're diving deeper is kind of that affordability from the insurance perspective. Dr. Ted?
Yeah. Well, we certainly are eager to learn how we can combine coverage from the public sector for part of the certainly we hope that it will cover things like cancer screening as well as some of the laboratory services, and then explore possibly more innovative financing to cover cancer treatment in certain situations where we know that it's an expensive or an additional investment. But I guess the next, or perhaps we should explore how we've done this or how this has been addressed for particularly in the area of pediatric cancer. Andre Elbawi will be joining us shortly, but also in other conditions requiring surgery. Maybe we could hear a little bit from our colleagues from the Kids OR as to how this is, how you've addressed the financial question of the burden or help cover the cost to the family of the interventions.
Thank you. First of all, it costs about $350,000 to install a fully functioning operating room. So somewhere like Zambia, where we have installed 9 operating rooms recently, both in Lusaka and in district hospitals. And that cost is a full cost. You get the facility installed and you get a maintenance and a warranty program. So that's the sort of scale of the cost. We can see from our data that an operating room will treat just about 600 children a year. So you then get an idea of how many you're going to need to meet the demand, and from that you can workforce plan. However, how do you tackle then the catastrophic cost of surgery to a family is then another whole ballgame. I have to say that our organization does monitor wherever possible through family interviews what has been the burden, the financial burden on the family, but we are not in a position, we're not an organization that pays for the surgery. So we will support, so in Zambia we work with the Ministry of Health, make the financial investment in the infrastructure, provide training for the engineering supplies, and sometimes make a financial investment in the training of the clinician. But the actual cost of the surgery is still borne by the family. And all we can sadly say is we see time and time again that it is still catastrophic for too many families.
Thank you. Oh, do we have a hand up there, please?
Yeah, just very quickly. I mean, listening a little bit to the discussion, I think we need to make a distinction between the public and private provision of healthcare services and public and private financing. I think that, in my opinion, whether healthcare services are provided by the public sector or the private sector matters less than whether financing is public or private. What we've seen from experience, and having done a lot of work myself in South Africa, private financing, in particular private health insurance, whereby individuals provide a contribution to a health insurance fund, because we of course need to define what insurance is as well. Insurance can be either on organizations whereby you collect contributions from individuals, but insurance can also be a broad concept of simply the government providing publicly funded healthcare services. Private healthcare insurance presents a number of challenges in the sense that often what we see is that the risk pools are very small. So few people contribute to the insurance funds. Healthcare services are expensive, and what happens, for instance, like happens in South Africa, is a lot of the private health insurance funds collapse because they are facing a number of very strong hospital groups which can set the prices and so on. So it's just to say that there's a difference between public and private healthcare service provision, which is less of a challenge. It's more about whether financing is public or private and what the mechanisms are to basically contract the healthcare services, whether public or private, and what the legal system is that is in place to do that contracting. So yeah, just a little apartheid.
Thank you. So we have a new person in the table. Her name is Dr. Kate Isoken, and she's a OBGYN from Nigeria, also a current fellow at the Harvard Program in Global Surgery. And this is the beauty of this kind of round table, right? Do we have the first lady of a government, a state, WHO, and private? When do you get an opportunity to sit down and actually hear from someone who's working in that environment? Maybe, Kate, you can talk about, so what is it like for people with, let's say, obstetric or OBGYN problems, the affordability aspects, and maybe offer some ideas about what a health insurance scheme should do or should not do.
Thank you very much. Thank you very much, Key. I'm glad to be in this environment. Thank you so much for the initiatives that are already on ground and the ones we're talking about. Like he has said, I'm a specialist obstetrician gynecologist with the West African College of Surgeons and currently a global surgery research fellow with the Program of Global Surgery and Social Change, Harvard Medical School. Okay, I actually have a question directed at Dr. Zainab. She talked so beautifully regarding the cancer health funds currently ongoing in Kebbi State. And she talked about childhood cancers and all of that. I don't know if there's anything in the pipeline regarding ovarian cancer. There's a lot already going on concerning cervical cancer, and not much is really in the pipeline regarding ovarian cancer. And as a first-line healthcare worker, I see a lot of these cases, and women are really going down. The mortality rate is huge, and that's simply because the presenting symptoms, the early symptoms are quite vague and can be very confusing with our regular GI symptoms of excessive bloating, lower abdominal pain. It's kind of like really confusing to establish that early diagnosis that would go a long way in helping to reduce the mortality from ovarian cancer. So I was wondering, Excellency Ma, if there is anything regarding ovarian cancer, which is quite huge right now in Nigeria and in other countries all over the world. If there's something in the pipeline, and if that is something that the House can really start to brainstorm on and start to really think crucially about. I am also currently doing a scoping review on trying to identify the current ovarian cancer gaps in terms of incidence, prevalence, screening, management, and that. So I'm hoping that as soon as I get that out, that perhaps I can create a concept note and see if, there'll be funding opportunities regarding, what I eventually find. So, thank you.
Thank you, Doctor. Everything you've said is quite correct. We all know that ovarian cancer is on the increase, as indeed are many other cancers. Better diagnosis, more awareness, and the numbers are rising. I was recently appointed as an ambassador for World Ovarian Cancer Coalition. For the reasons you mentioned, because it's so silent and people do not really know about it, and to try to increase, amplify the messaging around it, particularly in Nigeria and other low-middle income countries. But I think that the point is not just about ovarian cancer. It's about how best we structure our health systems, how we fund it better. And I like what you said about PPP directed towards health and PPP for the implementation of the health programs or for the financing models. So if we can get that right, at the bottom of everything, there has to be some form of financing, even for awareness. So for us to be able to include certain cancers, more cancers, everything, all the conditions, NCDs and infectious diseases as well, we need to have a stronger structure, and the way to go about it is to have more advocacy for better funding. Not just when we say advocacy, most of us tend to think about awareness, going to the rural areas and teaching people how to detect breast cancer and so on and so forth. But there is a huge opportunity that is being missed by not targeting the policymakers, the legislatures, the financial institutions, so that we can have better platforms for all our conditions. And to access it, then we can also target the population and teach them how they can best do it. But from my point of view as a clinician, again, this awareness comes into play, and that's to directly go to your question, which is how do we improve access that people have to funding? When we started the Cancer Health Fund, and right up till today, not many people know about it. So you have patients that are suffering with catastrophic out-of-pocket expenses, but they still don't know that there is this support that they can access right there in their own teaching hospitals. So those the message needs to be amplified, and also the system made easier. Here we are promoting an e-platform to a woman in, rural 100 miles away in Kebbi that has no internet access, and yes, she uses her phone to call her son in the city or send an SMS at the most. But how is she going to go on that complicated e-platform to try to improve, to get the assistance that she needs? So whilst we do have improvements in digital technology, then there should be some more focus on that and how to get it adapted so that the rural people can really benefit from whatever efforts that we're making.
Thank you.
Thank you. I would like to have our kind of people with a financial background jump into this discussion. I think, Your Excellency, and the ovarian, component of cancer, actually for me is very dear to my heart. I actually lost my aunt to ovarian cancer who raised me, and it wasn't that we weren't living in, a G7 country, and it wasn't awareness, because there was awareness in the US, it was social stigma, because, I'm Colombian, and, I came from a very conservative background, and for many women, it's just awareness, as you were saying, Your Excellency. But I also think it's financing as well as social awareness. So I'd like to turn it to Annie and Robert. I'm not expecting an answer, but you are investing in different things related to cancer diagnostics, X-ray technology. How can you help us, as you're hearing these real stories, to deploy solutions on the ground so that more women don't die unnecessarily from something that is so preventable?
Maybe from our perspective, the way we look at reducing the cost is really lower cost diagnostics. I think you were mentioning ovarian cancer. It's certainly one that's I think you weren't there maybe in the beginning, but we run an investment fund focused on women's, children's, and adolescents' health. And ovarian cancer diagnostic is very much an area that we have a particular interest in, as with all women's cancers, because today they're diagnosed by complex biopsies, and that's just not scalable. And so that's really our approach, is really to look at all areas of women's health from a diagnostic point of view. Can we make it cheaper, easier, and as much as possible where the sample can be collected by the woman herself, as opposed to having to have physical exams to address issues around stigma. And that's been our approach. So we've been less focused on the insurance area. However, we have come across some really interesting companies over the course of time that didn't quite fit what we were looking for, but that we admire a lot. There's one particular one that we've seen called Mango Science. It's an Indian company. And what they've put together is a layer of AI that analyzes the prognostic of the patient based on different treatment options, and uses the analytics to forecast probable outcomes with respect to saving their lives. And they pull together the financing, and the patient borrows, but they are not liable to pay the debt if the outcome isn't favorable. And so talk about putting your money where your mouth is when you provide a treatment. It's quite a fascinating approach, and I don't know, because we're not an investor in that company, one of their investors will be here tomorrow, if it's always tied to saving their life or to extending their life. But it's quite fascinating to think of tying the financing to the health outcome for that patient. And that's just one example, but we've seen over the course of time as well other schemes that are interesting from a technology point of view, where you can pay for maternal health services. So there was a company that we came across in Montreal. It was a woman initially from the Congo, and she'd created this platform for maternal health where the diaspora relatives could send money to pay for their relatives' healthcare locally in the country. And that's another technology platform, and it was a simple text where they could, their sister went to the doctor and they could quickly text $20 to cover for the maternal exam. And so there's all these platforms that exist out there that can serve as copay mechanisms. Many Africans or Pakistanis have relatives from other places that are very happy to cover some of these costs when they can't be covered by governments. And so I think it's really this idea of copay, I think, hasn't been exploited as much as it could be. And I certainly like to see a bit more of that, and perhaps in our future funds we'll look at those opportunities. But there's a lot going on in the fintech sector that can be leveraged to cover those insurance-type mechanisms where the tax base of certain governments is maybe insufficient to cover the entire care pathways for people. But for this current fund that we're investing, like I said, we're really focused on lower-cost technologies that are more efficient and have a component of upskilling local health practitioners as well. So that's sort of where we play.
Thank you, Annie. That sounds really revolutionary, and we look forward to hearing more about those different companies. Robert?
I'll give it a shot here. Can you just ask the question one more time, Joanne? So I want to make sure I get this right.
You were listening.
I am listening, and I'm learning so much.
You are too into Annie's comments.
There's so much information passing through here.
I think what we were, we've, gone from, structuring to the insurance to the affordability. But I think, based on what Annie said, there were some technologies that I think could cater to that base of the pyramid. But in terms of addressing some of the financial sustainability, the insurance, what do you see as maybe a financial way of overcoming this that you have either invested in or put on another hat and put in your philanthropic hat and see how you can, you know, provide solutions into it.
Yeah, so I can't speak to the insurance, but so thanks so much for sharing what's happening in Nigeria and also learning about ovarian cancer. I could take this information, I can go to my investment team of, let's say, the investment manager managing a gender lens investing fund, and then turn to the fund manager that's focused on improving African health, strengthening African health systems through impact investing, and ask them if it fits, right? And so they're going to look at, they're going to say, well, we have this company in our portfolio, or maybe we could, you know, put the team on looking at these different companies, and then they can come back to me and say, yeah, there's a fit or there's not a fit, right? Now if the answer is no, then those two funds, as well intended as they are, focusing on GLI and African health, cannot be helpful in this regard, right? So when I hear this information about what's happening in Nigeria and the issues around ovarian cancer, I don't just look to what our two funds are doing, but I try to understand who that has wealth, whether they're an investor or a donor, care about this issue, right? Because if they care about this issue, then I can put them into one or two containers. That's easy to do. And I understand their objectives and their tolerance for risk and their time horizon and all this, right? That every steward of capital does as a fiduciary. So yeah, the most important thing is to match those people up, right? I mean, a lot of people don't really think about this, but a fund manager has really three functions. They have to operate the fund, they have to generate investment performance, and they have to raise AUM. So if I'm sitting here with my container and I have whatever, 100 million, 250 million to deploy, it doesn't really matter because I'm one out of thousands. So how we show up is, okay, here's the problem. What's the solution? We don't have it today. We have to create it. So that could be pick the name, a DAF, a special interest fund, whatever, on the philanthropic side. Or, on the for-profit, it's equity capital, it's debt, right? We haven't used much insurance that way, but we could see how we could move alongside that. So, yeah, so I don't have the answer right now without talking to my team about whether or not we could be helpful in this regard, but I can certainly sit here as just a good citizen and say, okay, well, let's figure out how we can create it. That's actually, that's why I'm here, right? So I can do that. So thanks for bringing this to my attention. I'm learning like everyone else, and that's why I'm speaking about what we're doing in a way that I hope you learn from me, because then we could come together and see how we can co-create this, right? It's an alignment of purpose and heart, and then, right? If we're aligned there, then we can create it. And our role is to bring the capital to bear.
And I think part of, co-creation is, yes, we're creating a fund, but as we said in the case studies, is speaking the same language like you just talked about. And so we are counting on you, and as Dr. Key said earlier, we've grown the table. I think we're getting more specific, and hopefully with your help, Robert, Jasper, Annie, and others who I joined briefly, we're going to structure together and deploy together some of those financial solutions, because we are not the ones that hold the capital. We are not the ones that have expertise in that type of scenario, but we need you as we're deploying these end-to-end solutions for women and economic empowerment. With that, we're getting into some of the case studies, and we're thankful to be working very closely with CRDF and the Sustained Dialogue on Peaceful Uses to look at scaling some of the case studies that, we've discussed. How do we get more specific on the case studies, because they do have angles of, science and technology related to women's health. And I'd like to give kind of our co-hosts a chance to to explain a little bit more about what they're thinking in Ghana, and also, you know, to interject again in the discussion.
Thank you. As Robert said, part of our mission here is to learn and understand how the role of private capital can play in financing the sustainment of a dialogue around peaceful uses. So I've shared with each of you in the room a couple of pieces of paper, one on background on the SDPU. I won't belabor that point, that's available to you. Also on our event in Ghana and our hopes to widen the cast of participants in that event. So please do take advantage of that information, and if you think you could either benefit from or inform the discussion in Ghana around how to widen awareness, use, all of the things that we've been talking about so far around, again, it goes back to peaceful uses of radiation technology, diagnostics, therapeutics, the entire gamut of that. We're looking for folks who can inform that discussion, and are also looking for a platform to be advocates for their causes in those particular areas. So looking forward to going deeper into the case studies and understanding more about what role our program can play in hopefully catalyzing activity to advance the cause.
Thank you so much. We're going to take a very short 5-minute break. So much. And, you know, I kid around, but, you know, Jasper is one of those true leaders in, I think, the financial industry that, having worked with, you know, different types of development finance institutions, I think you're one of a kind, because you're true to kind of that social impact perspective. So really thank you, because, you know, a lot of the DFIs wouldn't have stayed on this long at all, because it's like, you have capital, you don't really need to hear us. But it's really, I think in all honesty, you've really helped to, you know, structure, and I've seen you do innovative partnerships where nobody else would, you know, really think of deploying some of that capital. And Jasper, you know, true to your commitment, you've been on here for a couple of hours, and we really are looking forward to working with Invest International as, you know, we deploy and work at getting some of these case studies, you know, to fruition. So I want to give you a moment to comment again before you have to go, and really in terms of the discussion to date, and you know, you've been with CGHD and some of our forums for many years, and hoping that as we move forward in this case studies, we'll count you as a partner. But Jasper, just want to take some time before you have to go to turn it back to you.
Yeah, thank you, Joanne. Of course, after such an introduction, I'm sorry to disappoint, because I don't have the bag of money with me here. But yeah, I can definitely commit the time from our perspective to see what opportunities there are. And I think whether it's ovarian cancer, whether it is, I mean, new technical solutions, there were so many things discussed today. So I think that's the great thing with the gathering that we have, that it's a substantial number of people, especially from different backgrounds. And for me, as I said in the beginning, that's also what blending or blended finance is about, that people really from different backgrounds, you know, come together and want to make impact in a specific area. I think one of the challenges will be to see how broad you make the program in the end, because if you talk about universal health coverage, you know, it's health demand, it's health supply, and it is health financing. And so all three components have to be incorporated to make sure you end up with one solution that certainly supports the base of the pyramid. And if you support the base of the pyramid, you generally also support anything that is built on that base. And so I think for me, it is more trying, and I was unfortunately indeed not to be there with a lot of friends in the room. But what I also noticed is that I know a large number of names. I know from most that I didn't know where you're from. So it would be good to have, let's say, one arena to play in and see what different roles are played, or what kind of expertise we have on the team. And it doesn't have to be all financial. Financial is, I've said to you before, Joanne, I mean, money is fairly stupid until you start using it. So that's the one thing we have to make sure one way or the other that we get to see. I'd like to know and understand more, and more than happy to look how we can bring this forward. So yeah, I was very pleased to be there. I wish you a good meeting till for the other little over 2 hours, and I'll be jumping off in about 15 minutes. But thank you.
Thank you so much, Jasper. So I think with that, we went into some of the cases a little bit deeper. I think in terms of the African continent, given, the effects of the last pandemic, I would say that supply chain would be key, and in terms of how we look at the case studies from many different perspectives. And as Jasper said, it's, how broad do we make it? But also, I think supply chain encompasses those things that are both have technical assistance, have equity, but are most needed in terms of reaching the last mile. So, Faustin, how can the group work with you in terms of moving forward and looking at a case study for that supply chain management, since you address the whole African continent in a lot of the work you do around supply chain?
That's a very difficult question. I'll try to give some views. What I like, Joanna, is first of all this group together here, full of different expertise, coming from different background, sharing ideas and best practices and things they've done. I think that's where we have to get to as well. On the continent, and to do that, we'll need to do it with the countries, of course. One of the ways I'm thinking of is using regional economic communities or bodies. So your COMESA, your EACC, your WAU, which are the organization my non-profit company ARC is working with today. So that could be a platform to share those ideas where the member states of those regional economic communities can learn from each other and from there maybe put resources together. It's not a scoop here if I say what we noticed during COVID was clearly that Burkina Faso were never going to be able to buy any doses of vaccine by its own means because they don't have enough resources and they can't do that. I've just picked up on Burkina Faso, but we can name a lot of other countries. So you have organizations like ACAM, which is 21 countries across West and Central Africa, who are trying to put together their resources to do pool procurement. These are the type of organizations we should be sitting with and talking about how we can do that. During the break, I was talking to a participant here, and I was saying, it has become a buzzword since COVID. Everyone wants local manufacturing. And when I sit in those conversations, I ask the question, what is the main issue we are trying to solve? Because we are not trying to solve local manufacturing. We are not trying to decide which line and which plant we're going to buy and put it where. We're trying to solve availability, accessibility, or affordability and visibility of medicine, so that people can afford. Can they afford it? Can they see the medicine? So that's what we're trying to solve. So do we solve that by blending local manufacturing and pool procurements and trying to get muscles so that we can negotiate prices down, things like that? But beyond that, do we have regulation in place? Can the product produced in Rwanda cross the border to DRC? Are the regulations the same? Will the medicine go and stop? Will the innovation that's going to come about scanning non-communicable diseases going to be accepted across borders, across countries? Those are the type of conversation that we don't always look at it. So those platforms can help us to do that in my views. Yeah, thank you.
So we look forward to working with you under the Women's Health and Empowerment Network closely to scale some of the work that you're doing. I'd like to pause, and I see that Gwen from Prudential UK has joined us. You know, we just took a little break, Gwen, and I knew you were going to join us. So we had been discussing insurance. We had Her Excellency Dr. Zainab discuss some of the insurance innovative mechanisms in Nigeria. And then we went into others in Pakistan. And I know, Gwen, you're thinking about some of the innovative insurance mechanisms in Kenya, and I was wondering if you could share your perspective before we moved on into other case studies, because you are, you know, one of the largest insurance companies in the continent, and I know we work together with you in Uganda to look at insurance mechanisms for the base of the economic pyramid, and now you have great innovative thinking in Kenya.
Thanks, Joanne, and I'm really happy to be here today. A lot of learning. I've actually been online listening, and there's been quite a bit that has been shared. So great forum, great learning. Thank you for sharing. So when you talk about some of the innovative ideas that we are pursuing, I think putting insurance and innovation in the same word sometimes might not be very believable, given that insurance doesn't typically make it to the dinner table conversation. But I will tell you what the key insights we have learned are. So like you mentioned, maybe I'll start with what we have done in the continent, across the Uganda and Kenya, but important to know that today I'm only representing Kenya as a CEO for the Kenyan business. So as you mentioned, Joanne, we undertook a preliminary business case in Uganda to look into a possible blended model to address a healthcare model for the base of the pyramid. And whereas we did not eventually end up going to the market, we learned a lot from that exercise. Our key learning points were around the need for partnerships across the entire health value chain. So that's with the health providers, government, insurance product manufacturing and distribution, pharmaceuticals and diagnostics, etc. Because if we were then able to get partnerships in play that allowed us to bring down the cost of cancer and healthcare provision, then it was definitely going to impact insurance premiums in exactly the same way. And that speaks to the biggest challenge we had as to that particular customer segment, which is matching affordable premium to relevant cover limits. And so the question then, and the opportunity we think that still needs to be explored, is the opportunity for a blended finance model that addresses matching affordable premium to appropriate care limits and partnerships that then allow for the lowering of costs. Now in Kenya, we launched a product, what we call a critical care product. And so we launched it for the middle income market with a maximum cover benefit of about $115,000, which is paid upon first diagnosis of a critical illness, cancer included. I want to take a pause there and just give you context of how our market is structured. So the way our market is structured is you've got, from a critical illness and specifically cancer perspective, you've got majority of the funding coming from out-of-pocket costs. And that is then followed by the National Hospital Insurance Fund, which is government funded, which we pay premiums for as individuals. And then you've got private healthcare. Now, within private healthcare, there's then the health insurance providers, and this is regulatory. There's a health insurance providers, and then there's a life providers. Prudential Kenya is a life insurance provider. So at a product perspective, the kind of product we provide is a health sort of life benefit payment upon the occurrence of risk. So this means that we will pay you only once the risk is diagnosed. But then you then take out the cash amount, and then as a patient, you can decide which health protocol to follow. Now, once we launched our critical care product, we had feedback from customers who said, we want it for our relatives up country. and for our brothers and sisters who can't afford such high limits of cover. So we went down to premiums as low as $9 per month, and we are registering some positive growth on that. The other things we've done is in the middle income segment is we facilitated free cancer checks to our clients in partnership with a hospital chain and one of our bank assurance providers. More recently, we've, based on the insights that we've generated from ESG perspective, we are actually just about to embark on a partnership together with the Ministry of Health and a few other partners to run a program where we are physically training health workers on how to manage cancer patients, how to demystify early screening and detection, how to shorten the period between diagnosis and treatment, etc. And so we think that as a responsible insurer, we've got to be able to affect the entire value chain. But as a private insurer, based on the experiments that we have run, our insight is that to be able to cater for the lower end of the economic pyramid, it is very difficult to do that without some sort of subsidization, given the experiment that we tried to run in Uganda. Thanks, John.
Thank you so much. And Gwen, since you've been listening, we look forward to working with you on kind of that case study and insurance to scale. Dr. Ted?
Thank you very much. Now we are happy to have been joined by another colleague from Pakistan who can tell us a little bit about the microfinancing that you've been able to do. So please go ahead.
Can you hear us?
Are you speaking to me?
Yes, so we went into the case study earlier on Pakistan, and I know, from a financial sustainability perspective, there's a lot that you've been doing with Sahak Kahani, and we wanted to hear more in terms of those aspects of financial sustainability.
Thank you so much. First of all, thank you for making me a part of this amazing, exciting conversation. Sehat Kahani is a telemedicine-based organization where we enable and empower physicians to practice or enhance or augment their medical practice further by using digital technology. And we do it in two ways. We create nurse-assisted telemedicine centers in very marginalized communities. But for the urban market, we have a mobile app. And I think our most winning feature has been working with the insurance sector, where insurance organizations, particularly health and life insurance companies, take this product from us and they make it available for their employees and their families within their value chains. And I think that is how, as an organization, which has been fairly new in the market, we have become financially sustainable. We're an organization who strongly believe on creating impact while also remaining financially sustainable. And I think out of all of the organizational revenue that we make, 70% of it actually comes from the corporate partnerships that we have built. So building partnerships with corporates, particularly the insurance sector, has really helped us not only increase the usage of our product, but also has helped us become financially sustainable. In our experience, the benefit the insurance sector has had in partnering with us is twofold. It gives them an edge as compared to the other insurance providers, that now people who are covered for insurance through them also have access to online OPD with not only general physicians, but a wide variety of experts and specialities, including mental well-being. But over time, what we have realized is their claims ratio starts to decrease, that now people can access a doctor online. That's the biggest benefit that they have seen, that their claims ratio has started to decrease. There's actually a study by UNDP that states that in around 6 African countries where all those insurance companies who coupled with digital healthcare also had a 47% reduction in the overall expense. So I think that's a really positive financial benefit that we have seen along with the insurance partners that we have. As we are growing now, we're also adding an online pharmacy. Again, it's going to be a unique online pharmacy, which is going to be for the consumers of those insurance-based organizations. So people who have insurance coverage now can also order medicines at home. And that's what we're working towards.
Thank you so much. Thank you for your intervention. And I think, you know, as we move forward in the insurance thinking, as Jasper said earlier before we dropped off, is really learning who's on the team, right? Who has the expertise to kind of deploy that solution, and how can we learn from each other's lessons. You know, one of the things that I know that Annie's fund is investing in is tumor boards. And so I know that while it's not an individual case study, it goes across all case studies. And, you know, we had the tumor boards, we also have the technology for x-rays. And I want to make sure that we can address a little bit of how we can use those technologies across our case study, and also give Prism a chance to speak, because you haven't spoken yet, and then I turn it to Annie.
Thank you very much for giving us the time to speak a little bit about Prism. So we've heard a lot of the different points today on how to get, first of all, these solutions close to the patient population. So that's exactly the mission of Prism, is to bring in affordable radiology services close to the patient population. So the idea is that we as a company not only develop the technology, but exploit that technology actually in our own center. The goal is not to actually, you know, sell the technology just as traditional OEMs, but really make sure that in the end, the patient that comes through our centers will actually receive a diagnostic report by a board-certified radiologist. And we know, as we've talked today, that 60 to 70% of those patients who walk through the door will be women. So we will set up our first center in Johannesburg in the September 1st. And we've talked a lot about affordability. So the entire mission of Prism was to see how we can make that final exam for the patient affordable. So in South Africa, as we know, there's 8.5 million people who are privately insured that get, you know, that have very good coverage, that have excellent access to excellent healthcare. And then the population that we are currently focused on, that is used to paying out of pocket, so they're employed, but are uninsured, and those are around 15 million in the country. And they are used to pay out of pocket, so we're trying to develop a price around $20 per X-ray exam, a standardized price, which is about 400, in the range of 400, 600 rands. If you look at what the insurance pays today in some private clinics, it's 800 to 1,000 rands. So the idea is already to have something affordable for the patient population. And then is to, we've just discussed with Annie, once you have these patients in the door, you know, we're talking about a typical day, 8-hour shift, you can get 40 to 50 exams a day throughout the door for standardized X-ray, is to say, how can we further expand to sonography, echography, and then also for breast cancer screening, because we know that's a huge need in this local population. To add different technologies in the center and have a one-stop shop where basically the GP can refer that patient, and then we send that patient back to the GP rather quickly. So the goal is that we have a 1 to 2 hour turnaround time from when the patient comes in the door, receives the diagnostic report, and then he goes back. Then he can go back to the GP, because a lot of times people have to take off work. If they have to go to the local hospital, it takes them 2 or 3 days. Sometimes they only get an image, but not actually a diagnostic report. So we've really been thinking about this from the beginning to the end. How do we make this final exam affordable for the patient? And part of our local partners, they've been working in the healthcare industry. Also from the funder's point of view, we've already discussed how can we then work with insurances and say, look, if we partner with us after we have a certain scale, we can negotiate price or offer even cheaper diagnostic reports for that patient population, have special contracts negotiated with specific funders. Or you can think of, we can clearly identify patients who are unemployed today. We can think of, if we have a global fund available for each exam that costs us today 400 rands, maybe 200 rands get co-financed by a specific fund. And then out of the pocket patient becomes cheaper, and it's very targeted to that specific exam, whether it might be a sonograph or maybe a breast cancer screening exam. So I think once we start to scale and set up these clinics close to the population, The goal is really to create a large footprint, not only South Africa and the SADC. We have also Kenyan investors on board, so the goal is also to go to Kenya later on. So I think we have, you know, all the different pieces of the puzzle that we all talked about. And to our colleagues from the supply chain, it was also always the goal from Prism's point of view to set up local assembly. So we've looked at potential partners in South Africa to local assembly the X-ray device. We've already found a partner that is FDA and CE approved. So it was always not just, you know, having the technology developed and assembled here in Europe, but also then bringing it locally because of all the, you know, supply chain costs that have increased for transportation, and also training local engineers, and to bring it to the different markets where we serve. So, yeah, I think there's a lot of points we discussed today that concern the Prism project as well, and happy to share and grow with you throughout this discussion.
Thank you so much, and we're looking forward to, you know, deploying those different solutions. Annie?
And I'll just speak to the specific opportunity that we're looking at in the tumor board sector. I'll say a few words and then pass it on to my partner, Donna, who's sitting there and knows the specifics, because it is an interesting case study from the perspective of blended finance. So we're a VC fund. So what we're looking to do is invest in this business. It happens to be a US-based business with a founder who is an immigrant to the US and is looking to expand the business to serve multiple countries, kind of reflecting her heritage. And so what the company does is set up to create these virtual tumor boards. So rather than having everybody meet in person, they're now able to meet virtually. So it's got an element of telemedicine attached to it. And what this group does, it's a multidisciplinary group, and they help, and this is a non-technology solution that's been proven to improve the effectiveness and lower the cost of treatment, because this group now decides on the most optimal treatment for that specific patient. So for the tech buzzwords people, it's got an element of precision medicine to it, and it pulls all the data that this group needs to meet. They're looking at it virtually as they're talking and making the evaluation for that specific patient, and they may do 5 to 7 patients in that 1 hour that they're scheduled. And so you've got all sorts of efficiencies that can happen, and upskilling. So if you've got a more junior oncologist there with a more senior oncologist, you've got that knowledge transfer. Now, this is happening perhaps in the US between a group of people that may be from a rural hospital to the best, more specialized center. So you've got that upskilling, but then you can imagine now you can run this between different countries, different levels of skill sets within that country. So you're not only offering the better care to the patient, but you're sort of improving the whole health ecosystem. And it's quite interesting. And from a finance point of view, and this is where I'll ask Donna to talk about the specifics. Again, we're investing in the equity of this business for it to grow and scale up. But for this company to grow across multiple countries, it will take different kinds of money. And so I'll pass it to you, Donna, to talk about the initiatives they're doing with pharma and other groups.
So just to add to what Annie was saying, it's not just oncologists and the GPs that are working with the patients, it's also radiologists, it's pathologists, it's the physiotherapists. These are complex cases. It takes a lot of people to look at treating that patient in all the needs that that patient has. So there's a multitude. They're already expanding into other countries, and they're either taken by pharma. There's a variety of pharma that have already brought them to different countries, and pharma are interested because there's certain insights you can get out of the data with AI, anonymized data. There's lots of insights that are there. So that's one reason, and they're also interested in expanding cancer care within different countries, and so you're bringing together the diagnostics, the therapeutics. And so if you can bring in some of those players, and we will be talking to parties that are in foundations. Example, we talked to one that, a person that's in a foundation for some of the radiology equipment. And so there was an interest in tumor boards as well because it brings in different imaging, and so they see the development of the ecosystem, and that's of interest to them. Interestingly, in one of the countries, it's the telco that is helping to pay alongside the pharma because they see this as just another use of their platform. So you can start to pull together different parts of the ecosystem to see where everybody can play and fund to bring it into a country. And then it's upskilling within the country, and then for the more complex cases, you can bring in different skills from outside the country. And you can even do it, we're interested in pediatric cancers, and so you could do it on a global basis for certain pediatric cancers that are rare, and you're really bringing together the people globally that can help impact that one child's case. And so that's why we're quite excited.
Thank you so much. And I see other people's hands up. We're going to take a very short break because they serve the food and it's hot and I don't want it to get cold, which is an awkward time, I have to admit. But if people want to quickly get food, sit down, we can continue our working lunch so that nobody's food gets cold.
Thank you so much for letting me kind of intervene, even though I know everybody's mind is on their stomachs at the moment. I found this conversation super interesting. I'm relatively new in the Unitaid team. It's actually a new position, and it's part of our expansion in the way in which we're looking at our resource mobilization overall. So to be here and to this conversation, to so many different people with different parts of the story about how we improve healthcare for women in low and middle income countries, and to hear the different perspectives, I think, for me at least, has been super inspiring. I know many of you heard Tenu, my boss, speak earlier today, and he was talking a little bit about Unitaid, but I think one of the things that's also really important to note is it is an organization that was founded out of innovative financing. And I think as we move into this kind of next thinking, we now need to move from those kind of innovative financing, which is part of the mix, into what looks like a much more sustainable financing for the whole of the ecosystem. And hearing the conversation today, so many of us have different parts of that story. What I wanted to add to that was, I know some of you were at the Unitaid launch of its investment case last night, so thank you for attending. But there we actually launched our investment case over the next 5 years, where we're looking at 30 different innovations, which we've highlighted because of their potential for impact around saving lives, first and foremost, but also looking at how much time we can save in terms of development, as well as what kind of cost we can save to the overall health system, and therefore kind of drive things where it becomes a much more sustainable market. One of the things that we've then been puzzling through is how do we make sure then that that best product gets into the right hands at the right time. And for us, that's really related to not only the product, but also the people, and that's why this conversation has been brilliant, but also the kind of partnerships that we can create. Unitaid's a team of just under 100 of us, to be truthful. And so we're a very small team that really relies on partnerships. If we don't have partnerships, to be honest, we don't have any program to go and deliver that then means that these innovations can get themselves to the market. So for us, this kind of conversation, these kind of fora where we can start to create that becomes super important to us. At this point, I guess one of the things that I can say is we're pretty good at looking at what the market dynamics are as an institution, so that kind of head case of why you should go and do this, we have a whole strategy and results team which are really focused on those two elements. What I've heard today is a lot more about what's the heart of the situation and what's the instinctive gut. And I think that for me is also going to be really important about how we bring this together to really focus on women and children's health. At this point, I'm going to say I'm really sorry that I have to bow out, but I'm really encouraged and I really hope that we can carry on this conversation.
Great. So we look forward to working with you closely under the Women's Health and Empowerment Network. Thank you.
Happy to. So I don't think maybe you can introduce yourself and the organization. I think he put some of their brochure on the table as well. Well, over to you, David.
Thank you so much. I might stand. My watch keeps telling me I need to stand up. And exactly. So thank you so much, Your Excellency. An absolute honour to meet you, and thank you for your time. I think when we look at case studies, what's important is that there are real outcomes to meetings like this. And what has been a pleasure is attending an event with exemplars in the field, people who are 100% getting it right. And I've loved learning about different projects. I've loved meeting new people and hearing about incredible things that are happening. With Kids Operating Room and Global Hospital, which is a company we own, we are trying to go to those who maybe aren't always getting it right. And sadly, that is the majority probably of the people investing in global health space. And that is because they don't always go end to end the way you're talking about today. So they will see their intervention and they'll go ahead and do their thing, but they won't consider, is there a local supply chain for that product? They won't consider, is there a local engineer capable of caring for that investment? And what will happen at the end of life of this thing that we have given this hospital? And is it going to end up rusting out the back of the hospital? So, Kids Operating Room is an NGO that creates surgical facilities, and we've become pretty good at it. We work in 27 countries around the world. And I think if you want an operating room built anywhere in the world, then I think our model works. I think it's effective. It uses local supply chains. It builds into the local system, and it does it effectively. Global Hospital is a company we own, and it is there to support any healthcare intervention or project. So if, and we were talking about Zambia earlier, we were talking about saying, well, is there capacity in Zambia to scale up access to care and to tap into the resources of the social security model? Then yes, we believe that there is, and that actually capacity can be created. And that it can be done in a way that supports the training of Zambians to look after that equipment, the training of clinicians to use that infrastructure, and it puts in place local supply chains. The goal ultimately should be to not be needed. And that is what I think we should all be working towards, a day when these countries say to us, thanks very much, we've got it now. And I think the way to do that, as you all, I suspect, will agree, because you're all doing it, is to strengthen the system, is to support from the things we're asked to support on, and then to step back when the time is right. I think that that's possible in every single country. I think it's definitely possible if we're going to focus on Zambia. And I know Professor Makasa's got some thoughts, can maybe pick that up and run with it. But I think that investing into healthcare infrastructure can be done in a highly effective way for any healthcare situation. And in women's health, it can absolutely be done in a way that every aspect of women's health can have the infrastructure and the local people that they require. We know the solutions to these problems. We just need to make sure we have the funding available to deliver them.
David, could you comment about the solar, just expand a little bit about the solar power aspect too?
Yes, so we hear constantly that power supply outages are a problem, and so we ran a trial in 4 different countries, in Nigeria, the Democratic Republic of the Congo, Tanzania, and in Kenya. And we monitored, first of all, what actually happened in the hospitals. And we found that in papers, in research that we're just writing up for publication, but what we found was that 5 out of every 6 days there would be a power cut in one of these hospitals in the operating rooms. When there was a power cut, the average time out was 99 minutes. And that on days when there was a power cut, the average time lost was 4 hours. So that means that in hospitals that are providing maternal health services, the ORs were going out for an average of 4 hours for 5 out of every 6 days. So if you want to immediately increase the capacity of care, then the first thing to do is get your current systems working. So we designed a fairly straightforward system, smart battery, solar panels, which means that you can deliver an operation when the sun's shining purely using solar power. You can, it will maintain the battery at 100% so that if it gets dark, then the battery will provide that power, and only rely on the grid as the sort of third and final requirement or source. And so in order for that to happen, you'd have to be working deep into the night before the grid was needed. This reduces the cost of providing care for the hospital because there's no electricity costs. It increases the patient safety because the power remains stable. And it reduces the carbon footprint of the hospital. By a huge amount, no, but by about 1.5 tons a year per operating room, and that's something. And sorry, Professor Mukasa, you're totally right. What this system does is it protects all of the equipment. And so what actually was happening was when these power outages were happening, the surge would then damage the equipment. And so you then have redundant equipment in the operating room. And this system, you'd think I would know because I was involved in designing it, has a force strength, and that is that it protects all of the equipment in the operating room. So again, that can allow safe surgery to happen in any hospital in Africa. So we know the solutions. We can provide surgery, we can provide increased capacity in hospitals without a huge investment. And we can make sure that women, particularly women going through childbirth, where there's still heading towards 800 women a day, will die in that situation, which means we can put a measurable number on it since this meeting started. We can immediately tackle that by simply increasing capacity from the existing stock of hospitals.
Thank you, David. And I think, as I'm hearing an echo of supply chain in each of the different case studies, it seems like supply chain is not a case study unto itself, but is actually part of the many different verticals we're trying to look at in these case study for Zambia. And David, Dr. Key introduced us, so you're responsible, Dr. Key is responsible for having you as a case study at this table. So we're really, looking forward to it. And I don't know if there was something else you wanted to add.
Yeah, no, this is I'm still lingering with the impact of what you said at the end, the emotional impact of that. Thanks, David. And also you mentioned about the end-to-end care. We have so many groups here who have really niche interests and expertise. But at the end of the day, we need something that's able to operationalize some of these things that we want to do, and it requires all the components. I want to just ask Dr. Emmanuel Mukasa to sort of chime in at this point, because he is an orthopedic surgeon from Zambia, so he knows what it's like on the ground, but he's also worked at a high level in policy and now really working with the 16 countries in the Southern African Development Community to implement their national surgical plans at district hospital levels. So let me go over to you, Emmanuel. Go ahead.
Thank you, Key. So like I said in the morning, any investment needs a mechanism on the ground through which that investment can actually get to the ground. And obviously, it also provides space for government itself to make the initial investment, because you can't always be asking when you're not making the investment yourself. And so that's why we have taken the commitments that governments have made at the global level. We've had agreement at SADC level, and now we are at country level supporting the countries to first formulate those needed policies. They are cross-cutting, they are complex, they are difficult to understand, and then cost those policies, and then of course start the pilot part, like I said, to demonstrate impact on health system strengthening, health outcomes, improvement, the socio-economics of what we will invest in. Now, if we zero in, for example, in the Zambian scenario, The policy that we are revising now gives us room to expand already what Professor Roma Chilengi alluded to. The social health insurance for us has been a game changer in terms of service delivery. As you heard, it's a government mechanism. It started with the public sector, and obviously private sector is coming on, and even the individuals are coming on. But obviously it doesn't cover everybody still. We still have gaps in the social health insurance that need to be closed, that we hope investors or colleagues and partners here can be interested in, because the government has already taken the bigger chunk of all this. And then, of course, we want this service to be provided on, as close to the people as possible. And of course, maternal child health becomes the priority. It's the entry point. It's the best investment that we can actually make that will touch not only the individual, but it's the family, it's the community that will be, impacted by this. Now, we still need to create the service, have investments in the delivery mechanisms, because we do have social health insurance everywhere, but then we don't have the facility to actually provide the service. I can pick a rural district. It has a district hospital, but it may not have the equipment. It may not have the health workers. It may not have other things, and yet people have actually paid for the insurance. Those are gaps that we hope that we can close. And we are looking, and we are very happy to have partners sometimes like Kizor, who actually help us equip those facilities, maintain the equipment, like you heard, with a stable supply of electricity. Biomedical equipment is very expensive. If you've been to Africa, you know that most of our facilities are graveyards of biomedical equipment that was procured at great cost by government and, of course, the partners. Sometimes what blows up is simple things because of the fluctuating power supply. So that investment for us is a game changer, and if we can have that, then we can ensure that all the facilities don't only have equipment that is safe to provide safe surgery to the people, but also it cuts down on a lot of costs. So creating those delivery mechanisms, ensuring that we can actually implement the policies we are developing on the ground is key. Because like I said, that's the framework. If we cannot demonstrate that impact of what you're investing in or what we're investing in, then again, it's an effort in futility. But then we also there are also other opportunities that we have on the ground to unlock further funds that can come into the insurance. For example, the social health insurance in Zambia does not cover accidents. We have a lot of road traffic accidents. We have a lot of industrial accidents. We do have accidents even at the homestead. Now, that component is usually not covered, and the private insurances also don't cover it. But we have been brainstorming, and we've realized, for example, that motor vehicle insurance does cover the patients that come from this trauma, especially for the road traffic accidents. Every vehicle driving on the Zambian road is insured. And the primary target and recipient should be the victims that survive from that road traffic accident. But we haven't created mechanisms to follow up when an accident happens. Patients are brought to me at the university teaching hospital, and I'm struggling. I don't have sutures, I don't have bandages, I don't have this to use. And yet these patients were already covered in that vehicle. So what we lack is the mechanism to try and follow up to ensure that those insurance companies that insure those vehicles can provide the care upfront. What we have seen usually is that nobody follows up these issues, and then we mismanage the patient because we are lacking resources. And at the end, as you know, they end up physically disabled. In our environment, you cannot survive very well if you're physically disabled. And surgical disease is physically debilitating. We need our hands and our legs to earn a living. And so compensation that we have to now compensate people based on schedules that were made in 1972 is not appropriate. We want the money from insurance companies to come up front so we can have all the supplies and equipment and resources so we can treat these people so they can get back to work and grow the economy that we are trying to do. So those are the areas that we see specifically for Zambia that could be helpful. We expand the social health insurance. We ensure that we can put in the delivery mechanism to actually ensure that those who are covered can receive care, because like I said, you can have the insurance, but if we don't have the machines and everything to actually provide the care, then you're paying, but you're not getting the service. That's not okay. And then we are also innovative. We want to unlock other areas that can bring money, that can cover the trauma, because the trauma component is very big. And we're losing the most productive age group in our population. We're in a hurry to get developed. We need our people to be healthy to develop.
Thank you very much. Now I'd like to ask Dr. Andre Elbawi from the cancer unit at WHO to talk a little bit about their pediatric cancer initiative, because I think that shows another model of both a broad vision as well as the kind of the hands-on approach to making sure that all the key elements are in place. Andre.
Thanks, Ted. It's great to see everyone. I'm sorry we missed the first half of the meeting. As Ted said, I work at WHO headquarters and lead the cancer program. One of our primary areas of collaboration is in childhood cancer with international partners. One who may be known around the room is St. Jude Children's Research Hospital. So about 5 years ago, we launched an initiative called the Global Initiative for Childhood Cancer. It set an ambition of improving survival from 20 to about 60% for all children with cancer globally. 70 countries, including Zambia, and we're most appreciative for the leadership of Zambia, have taken on this initiative and have worked towards its target. But as we started implementing the initiative, we noted that there was still a persistent challenge with access to medicines. And so we took a step back. We spent 2 years with St. Jude looking at the market, trying to understand what were the reasons for these market failures. The market failures, of course, would include dimensions like stockout. We've heard quite regularly today, high cost of these products, which is paid out of pocket with financial hardship or abandonment of therapy, and the general availability of the products because of a variety of market factors that constrain products being available in low and middle income countries. So after 2 years of research, we announced a commitment, and St. Jude is funding it with a $200 million upfront investment to provide free, effectively for the purposes of just sharing with you the context, but medicines to all children with cancer in 50 countries by 2027. So we started now looking at the type of end-to-end support that's needed, and it's nice to hear how many people are thinking about that end-to-end. I think Key, you raised it, but it starts all the way from the pipeline. What's coming in the market? How do we make it more relevant for children in need in low and middle income countries? For example, looking at formulations. A lot of the formulations are given IV, but there may be a subcutaneous or an oral formulation that would make it more user-friendly for the families. So how do we shape the market up front? Then once we've identified the country, how do we work to evaluate the country readiness? We do a full supply chain evaluation. We try not to duplicate. We looked at Zambia as an example. I think Zambia has 6 supply chain assessments in the past 2 years. So it's just, again, how do we avoid duplication? How do we build into existing work streams? So once we've identified how to build those capacities in a country-led process, then the products are made available. As part of the readiness evaluation, we look at diagnostics. So we don't stop and just drop off the medicines. It's not a donation program in a pure sense. The intent is to provide the medicines, but to build the ecosystem around it. So we're looking at how to bring in development partners or banks to help finance diagnostics, so that if a country has a gap in flow cytometry, is there a partner who can come and help finance that specific request as part of the overall platform activities? And then with it, we're also building data systems so we can track what happens to the child and making sure that the quality of care is optimized and the long-term outcomes are documented. So 150,000 children will start in about 3 months. All the background work, again, we've spent now 3 years getting it ready. And WHO does a lot of procurement, usually in emergency situations, so we're quite comfortable with the project, but this is the first time we're going to such a large scale. UNICEF is the procurement agency for this platform, with the exception of the Americas, for which PAHO, the strategic fund, will do the procurement. So we're very excited, and I think there's a lot of opportunities to collaborate with stakeholders around the table, and look forward to, if there are any questions or comments, happy to discuss further.
Thank you, Andre. We're looking forward to working with the WEN partners and a lot of the great initiatives that you have around the table. Director General, there's a lot that's been said about Zambia, so I want to give you a chance to comment, and then also, we are looking forward to that end-to-end care, as David said, and for that women's health perspective. But if you could take on the comments that you've heard around the table, and lead us to some next steps in working with you.
Thank you very much. I think that the conversations are really important windows in what can be, at least in my mind. And we certainly appreciate that there's quite substantial focus and interest in seeing what can be feasible for Zambia. Besides what Dr. Makasa has talked about, I think a big challenge for us, we have many challenges, but an enduring challenge at the moment with the lens of universal health coverage is how do we provide the very basic of cover for the children and the women out there in the remote sort of areas. And I think that there should be innovative ways to really come up with mechanisms to provide that support. From what we're discussing, and then during break, I was thinking that it is probably an opportunity to look at the gaps that the current health insurance program in Zambia fails to cover. It does provide some minimum cover, and surgical hospitals from the are now able to claim part of that insurance based on the costs that but it is limited. So is it possible to have a program that then bridges that gap, which could be maybe very, very prescriptive as to who would be, what conditions, or who would be eligible to access that support, that is ring-fenced within the insurance mechanism, and that's what, an investment may come in and provide cover for, so that that child or that woman who meets that criteria then accesses that support and gets a full complement of. And I think that would be a win-win situation, starting really with the intended patient themselves going through it, to the hospital and the doctors and the system providing the care, but also to the investors or the donors or partners, whichever the case may be, because then they are not just being catalytic to a process which would otherwise have failed. I think that their intended means are being satisfied. And in terms of the impact, they can objectively quantify that impact and measure it and be able to show that because we invested, this is what is coming out of that investment. So in my mind, I can see a possibility of that. I'm only a professor of vaccinology. I don't know too much about money, but I think that it is possible for these kind of things to happen. We really talking about the solar energy for health facilities. This has been a very, very important component of our conversations in government. Actually, our president has given a directive that we must not have a health facility without running water, without basic lighting, which in rural places has to be solar driven, and a mother-child sort of facility for women to safely deliver in. And that's a very, very strong directive. And thinking about the conversations we are having here, again, to Dr. Makasa's point, the government in Zambia is already taking lead. And by the way, in the constituency development funds that I talked about, they have already given guidelines to insist that where there isn't these facilities, they must get those constituency funds too. But of course, there is a lot of bureaucracy and processing, especially in the more remote areas, to make sure that the patients get this. But there are a lot of opportunities in this space, given what we are discussing here, that we can take advantage of and really have something very quickly to show impact for. I don't know whether this is the right opportunity, but I'll take it anyway and say that in November, end of this year, we are hosting the Continental Public Health Conference. This is the conference on public health in Africa. We are anticipating almost 5,000 delegates from all over Africa and all over the world. And I would like to put it out in this meeting that it would be great to have a side event that then looks at, from World Health Assembly to CIFIA, we call it CIFIA, what have we achieved, what progress have we made? And so it's an open invitation. Thank you.
Yeah, and I think we take on that challenge, and I'm going to take on the challenge with some of our current members of WEN, who do include some of those women philanthropists and also equity investors, to take some of that financial conversation then with deliverables. So we take that challenge, and we'll work with you closely on that case study as we deploy as.
So Rebecca is on, so should we, we're not seeing her. So, there they are.
We've been lurking for the last half hour, just watching and seeing all the amazing things happening.
Well, we're delighted to have our friends from Rice University join us, and we'd like to have them to present a case study of their terrific work in the field of biomedical engineering. So I'll ask Rebecca and Maria to present. So please go ahead.
Sure. Thank you so much. And thank you for inviting us to participate. It's been just amazing this last half hour hearing the amazing case studies that have been happening. Rebecca and I are bioengineers, and we've been long involved in developing medical technologies and teaching students to do the same. And we co-lead an organization called NEST 360, which is a consortium of 17 organizations, 13 of which are in Africa. And this consortium is laser focused on ending preventable newborn deaths in hospitals. And this group represents what you would expect, which would be clinicians, but also biomedical engineers and technicians, commercial entities such as local and global distributors and implementation researchers. And NEST 360 aims to be an end-to-end solution, like was described before, where we're looking at all of the barriers that are in place that keep us from ending preventable newborn deaths. And I wanted to start by just talking about where we started way back in 2006 and 2007, when Rebecca and I visited hospitals and went into newborn wards and saw the fact that there were just amazing clinicians that didn't have the tools they needed to be able to give the care they wanted to give to babies. And as moms, of course, that is just simply heartbreaking. At the same time, we were taken down the hall and went to what was referred to earlier as an equipment graveyard. As engineers, that equipment graveyard is also heartbreaking, because what that represents is technologies that have been put in place, but maybe they're not the right technology for the right use. Perhaps they're not rugged enough, or perhaps there aren't biomedical technicians to repair that equipment, or a good local supply of spare parts and consumables for that equipment. So when you couple these two things, the babies that desperately needed, for example, access to oxygen concentrators, and oxygen concentrators sitting idle and unused and broken in the equipment graveyard, we knew we had to work together with our local partners to solve this problem. And at the surface, in terms of thinking about the equipment itself, we know we need biomedical technicians, but we also need biomedical engineers, local biomedical engineers, to invent and qualify rugged technologies for use in this environment. And at NEST 360, we're doing both of these things. The team is developing and has developed education materials and courses, skills labs for pre-service training, but also for in-service training of biomedical engineering technicians. We're working in 4 countries right now, Malawi, Tanzania, Kenya, and Nigeria. Soon we'll be working even more in Ethiopia. One activity that we have undertaken with UNICEF that we have found to be really impactful is that we've developed with a group of clinicians and technicians and industry partners and UNICEF target product profiles. And what these target product profiles are is the specific need within a particular technology. So what exactly are the specifications that a particular technology might need to meet? And having a listing of these and having them publicly available on the UNICEF website has signaled to manufacturers what is needed and innovators, what is needed for these particular products. And then we've worked to look around and landscape existing technologies and bring them into the lab and test them to see, do they meet the specifications and do they meet these target product profiles? And by creating a list of what we find are rugged and effective and highly usable technologies, that helps others when they're making decisions about what to purchase. For biomedical engineers, we've started invention education efforts at universities, which include design studios, where students and faculty can go in and create solutions to locally identified problems. Some of the inventions that have been worked on at these design studios include, for example, something we call Lucia, which is a cervical cancer screening and treatment training system where nurses and clinicians can practice techniques, for example, for identifying surgical or cervical cancers and lesions. CPAP device has been developed. During COVID, the design studios were able to respond in an amazing way when supply chains weren't available. For example, the design studio in Malawi created 80,000 face masks to be able to protect the local healthcare workers. They developed hand washing stations and sterilization rooms, all just local solutions to problems that were happening locally. They were able to jump in and solve these problems. One of the questions we were asked to address is how might some of these efforts be scaled in partnership with the private sector? And one of the ways we've worked with the private sector is was mentioned earlier about supply chains and thinking about how do we, particularly for our situation, how do we get newborn technologies to be available and sold locally in these in the countries where we're working. And that has looked like creating a global distribution system that's nonprofit that works with local distributors or local businesses to ensure that when some of these products are sold, that there's an actual representative on the ground to uphold the warranties, for example, to make the repairs, to make sure that the consumables are available, all of those kinds of things. And we feel very strongly that business and market work is absolutely critical to the long-term sustainability. And we can imagine that thinking about when we, for example, install new equipment, make sure that there have been adequate training, not only for the clinicians, but for the biomedical technicians, and that be built into the cost of the equipment that is sold. We think the private sector could invest in skills labs, in faculty development workshops for trainers of biomedical technicians, as well as the technicians. And, I just would say that from our work, it's been absolutely critical that when you're tackling a clinical medical issue, that you also have to tackle whatever technology issues are associated with getting the technology placed and put in the facilities, and making sure that the clinical team knows who the biomedical engineers are at the hospital and who to call. So the thing I'll end with is one of our, I would say, most successful trainings has been when we bring the clinicians and biomedical technicians together for the trainings so that the technicians understand why is this equipment so important, and the clinicians understand who to call when a piece of equipment breaks. Rebecca, what have I missed in this quick summary of our work?
I just wanted to add two things. One is that we have developed a monitor for any piece of equipment that plugs into mains power. And there is a dashboard that can monitor when the power is on or off, when the piece of equipment is on or off. So we can actually look on a dashboard, and the biomedical engineers within the Ministry of Health can also look on the dashboard to tell, is equipment being used? And if it's not, that can trigger an intervention to see if it needs to be repaired. And with that, we've been able to keep over 99% uptime of the equipment that has been provided for newborn survival. And the second thing that I'll add is that just like biomedical engineering in the United States, we see that there are a lot of women students that are really attracted to the opportunity to study a field of engineering that has such a strong impact on health. And we're seeing the same thing at the African universities with whom we're collaborating. Thank you.
Thank you very much. It's exciting to hear about what you all have been able to accomplish, and we hope that we'll be able to work with you and some of the people around the table here to see if we can grow the great work. And certainly, as we heard earlier this morning from David, the Kids OR group has also been working to help train people to fix machines, and not only in the pediatric ORs, but elsewhere throughout the hospital. Do we have any questions for Maria or?
So, thank you, Rebecca and Maria. I wanted to raise a question even before, but I think you've answered part of my question, because as we look at what David told us about the biomedical engineering problem. So I was thinking, like, among the things that we need to do is to get, the equipment, deliver the equipment, put the equipment in the hospitals. But I was worried about what happens afterwards. And one of the things that we know is that, as said earlier as well, when the equipment is there, if there is no maintenance for the equipment, then we are lost. But the other part is that we need to have the people that know how to do that, and that the people at the hospitals need to know who to talk to and to actually negotiate at the moment, even if it's a donation, at the moment of receiving it, that all these aspects are considered. Because this is super important. Otherwise, we actually continue in a circuit that we will never improve this. But my other question was, like, if you actually are able to deliver equipment, as you say, like something that is not used, that you actually make it feasible to be used again, what happens when technology evolves? I mean, is your project ready to actually support those who you are supporting to move within the platform that you're working on the technology, but to a new equipment, to a new device, or something like that? That was one question. And the second question was a little bit for the three of you. It was, and for all the audience, because we've heard about equipment, financing, rural areas, everything that we need there. But what we need in the rural areas as well are all the medics, the medical people, the physicians, the nurses, and everybody that has to give the service. And I wonder, I mean, at least from my experience in the countries that I've visited, the further you are from a big city, the less likely you are to keep the trained personnel, that you invest a lot of time, and they are very keen on continue doing this, to be there for a longer period. So what are the strategies that you've used to actually maintain? For instance, let's say you get to have a gynecologist very specialized in doing this type of surgery. How do you keep that person that far away for a longer period?
Yes, go ahead. They were running out of batteries, but.
Thank you. Thank you for that question. Yes. So the policy that I said, which is a framework that helps the investment, whether from government or private sector or donors, is comprehensive in that it actually looks at all the building blocks of the health system. Human resources being the key pillar. Now, the strategies that we can use or are using again, I'll use the Republic of Zambia. Some of these things are measures that government is already working on to implement. We know, and it's true, that in the rural areas, meeting the doctor is difficult, especially a specialized one. But government has a plan that we want these kind of services to be provided at the district hospital, meaning that we need to have those that can actually diagnose, be able to take the tissue diagnosis, if, for example, if it's cancer, or even manage these cases at the district hospital, because that's the closest we should do that. This also it supports the primary healthcare, levels, the clinics, the rural health facilities going down. Now, yes, of course, what's the challenge? The first challenge, obviously, that government has to deal with is dealing with the establishment. Government is working to open up because the establishment basically says the structure of that facility. There are specific staff members or people that should be at a particular facility. We know that in the past this has not been possible, was not done, and so it couldn't allow government to position these trained staff in those areas because then we'll have to take a surgeon and put him in a junior position in a district hospital, which doesn't really work well. Okay, that's one. Now, the establishment, once it's unlocked, and the minister, I think, has already been speaking to. Today, our Minister of Health has been talking about redistributing human resources or trained healthcare workers within the country, because most of them are concentrated in the big cities. And of course, like I said, issues of establishment, and that's what has come from the medical fraternity themselves. They are willing and very able to go and work there because they themselves have also realized other benefits that are in the rural areas. In the city, we struggle with space. Everybody wants land, businesses. In the rural areas, those opportunities are immense. And the doctors already know this because they've been working, and so they are keen to go. But those things needed to be put in place so that they can go actually work in a position that is appropriate for them. But of course, there are other issues that they may need. Issues of schools for their children, issues of power supply. And as government has a big component of renewable energy to electrify the rural areas with solar energy, and we have unlimited solar energy in our country. Those things are going to stabilize the other needs of power. And of course, the government is also investing heavily in infrastructure, roads to these rural areas that could be accessible, ensuring placement of other banking and other things that the people in the rural areas may need. And obviously, these again are going to make the rural areas much more desirable for the people to work in those facilities. So it's the policy. The policy is being revised. It will allow for inclusion and placement of specialized health workers in the rural areas. And of course, there will be other things that are going with it that are not really coming from the health sector, so to say. Like I said, there is education issues, there is energy issues, and government systematically is doing in those areas. But of course, government cannot work alone. The country is big, the needs are many, and that's why donors and partners are needed. And we're not talking about just investment in health. There should be other donors that can deal with us on the energy part, not only for the hospitals, like he has said, but there's energy for schools, the energy for households, So that's how we're approaching it. It's a systematic thing that needs to be done. Government at least has the commitment. Government has made the effort and is making steps towards that. And that's why we're here. I mean, if we're not committed and we're not interested, we wouldn't be sitting at this table discussing this. But thank you for raising that issue.
And I think we take on the challenge, as we had said earlier, and we just been discussing it with Dr. Ted and Dr. Key, and I'll let them comment. But it's kind of like a football team, right? So you're going to need different partners at the table. The investments, the technical partners, the supply chain management. So let's take it as potential.
Just a quick add-on. In terms of because again we have done studies on the health workers to find out. When they leave the rural areas, because they've been placed there before, why do you want to leave? What would you want, for example? The things that they want usually sometimes is that, they want more money, but what do you want to do with the money if we give you the money? They say they want to buy land, they want maybe vehicles, stable, better vehicles. Government owns land. Government can make land available to these health workers in those specific areas and create a mechanism where they don't have to pay us upfront. They can pay in 60 years. So they are tied down to that particular area. Government can procure vehicles that may need me, because sometimes the rural area you may need 4x4 vehicles. Government can procure 4x4 vehicles and give these health workers and give them to pay back over a long time. So government has mechanisms that they can use land, they can give land to these health workers so that they, like I said, they can build their house or they can have their farm and then they can pay back slowly. But that helps with the retention because these are the things that they want money for. They want money so they can buy land. They want money maybe so they can have mobility. And government has access to these things and can provide those resources. So we have options as a government.
Thanks, Emmanuel. So there's a joke in medicine. It goes like this. Internists, they know everything, but they do nothing. Surgeons, we know nothing, but we do everything. And pathologists, they know everything, but they do it too late. And the point, I mean, we have Andre as a surgeon here. Is it orthopedic surgery, right? Macasa. So we're all surgeons, at least some of us here. We don't like talking all the time. We gotta cut something out or, remove something. So let's move on to some action, right? Can we get something done? The DG actually has made a beautiful challenge. I think the stars are lining up. The African Public Health Conference is being hosted in Lusaka end of this year. That gives us sort of a deadline, if you will, maybe by November. And the challenge is, and you presented maybe one or two ideas. One is this gap insurance idea, right? To expand services, maybe specific to maybe women or women and children. And then the other one possibly could be building some capacity. Not so much actually building the building, but having a deal that can be announced maybe as early as November. And so I want to put that out there and see how this group wants to move forward. Yeah.
Well, I think we take on that challenge, right, Dr. Ted, and I think we'll look at the different deal structures with your help in Zambia to see what can be accomplished, what can be scaled in terms of technologies. I've had a lot of questions both from our online kind of closed circle participants as well. I think what we're going to do as a next step is we've gotten really specific on the types of case studies, the blended financing mechanisms. We're going to take you into smaller groups under one. So they're not going to be big public discussions. We're going to take 4 or 5 into kind of that structuring, that next step of how we move. Because we now know each other. We were joking around, but we've created kind of those trust circles where we can move forward. And I think, we take those for granted, but in a lot of deal structures we've put together, I find that the same 3 or 4 people are coming back in these large $350 million vehicles because it is a trust circle. And I think, we begin to know each other better. And so I suggest we move forward in kind of 4 or 5 as we are looking at the case studies in Zambia and Pakistan. Supply chain, we see across the different kind of avenues. And then looking at the technologies that can fulfill that need, both from an X-ray perspective, from a supply chain, but working closely in terms of women's leadership as well. We can't forget the W in WHEN, right? The Women's Health and Empowerment Network, and having the women at the helm. And so I turn to Annie because she's here as one of our equity investors. So I know, Annie, we're going to count on you and Robert to be able to, move us forward. And we have commitments from others at the table who have joined in WHEN, at an original stage to move us forward within this process. I think a little bit that we've kind of taken for granted too is the dialogue on access and how we move forward. And Dr. Ted, I don't know if you want to say other things.
Well, I certainly support Joanne's ideas for moving forward. I think we need to reflect on all our discussions this morning in terms of the financing, the insurance, the wonderful case studies that we've heard of, how to build on the technology, how to make sure that we train bioengineers and technicians, as well as the cross-cutting issues that we've heard about, whether it's supply chain or strengthening medical imaging, strengthening the diagnosis of disease, laboratory services. So I think we have a number of areas that are prime for close attention and we hope rapid progress as if we work together as a team. So I want to thank everybody for their input and their continued involvement.
And I think before we conclude, I just want to go to two people who have been silent but leaders behind the scenes. Steph, you've done a lot in access, and if you can comment briefly on access, Malinga, you're everywhere. And, as Dr. Key was saying, I think you're like that surgeon. You quickly get in and get us moving. So, Steph, I'm going to turn to you first and then to Malinga in terms of kind of, the access journey and how, you're seeing a lot of what you've heard in today's conversation.
Can you hear me? Yeah, it's working. Thank you, Joanne, for this invitation. It's really great to be here in this room, listening to all global leaders that are aligned to tackle access to healthcare and quality healthcare services in low and middle-income countries. Part of the Roche team. I lead access strategy in Roche for low and middle-income countries. I have had the opportunity to work with tremendous leaders across different continents, creating partnerships where we bring together governments, healthcare providers, private sector organizations, policymakers, to create together end-to-end care platforms, and particularly focusing cancer care in the space of women's health. And in that capacity, I have had the opportunity to work with Hafsa in Pakistan, one of the case studies that we hope that we all get our hands around in the next few months to scale impact and to scale care for many, many women that are still needing leaders like all of you. Dr. Zainab, who was here, I had the opportunity to also work with her in Nigeria in the space of cancer care as well. And I really hope that as we leave this room in the context of the World Health Assembly, we get more tangible in what are these next steps and how we can get all this beautiful energy and great work that all of you are part of to make sure that we scale impact that can benefit many, many, many more women across different continents. Because one thing that you all have said and that sticks with me is the importance of starting small, but also that the magic happens on the ground. And instead of parachuting strategies from different geographies, I think that we have a beautiful opportunity here to really make sure that those leaders that are making the change in the ground are enabled by all the expertise, technical assistance, and of course the funding they need to scale these beautiful study cases that we have been discussing here in Pakistan, in Nigeria, and Zambia, and many other examples that were shared. So I wanted to leave you with that note. It's a call to action. Let's really think how we can get our hands around these cases and make sure that the next time when we meet, probably in September, we already have some quick wins that came through our collaboration as global leaders in the healthcare space. Thank you so much.
Thank you. Malinga, and before you continue, Ikuyu, who's been on this journey with us with the Japanese International Cooperation Agency apologized for not being able to join, but did send a message through and really reiterated kind of his commitment to working with the Women's Health Empowerment Network of these network leaders, but also their initiative on impact investment for global health that was announced in the G7 communique. So looks forward to working on some of these next steps with us. Malinga, over to you.
Yeah, thank you very much, Joanne. First and foremost, I would just like to congratulate all of you guys who put in a lot of effort to be here with us and to look at the case studies. I'm not going to be speaking as a Zambian national, but I am definitely very proud that the Zambian team has risen to the occasion and put forward their best foot forward, Professor Chilenge and team. And let's look at Zambia as a case study. And let's prove ourselves. We do have now time to come back with tangibles by the time that we're meeting in November. I think it's 27th to the 30th of November, to see what we have been able to achieve until then. All right. Secondly, from a supply chain side, as a member of ARC, clearly supply chain is one of the most difficult areas that we are facing on the continent. But I think working smarter, better, together, we can achieve more. And I look forward to working with all of you to achieve those three things: smarter, better, together. And for the kids on the continent, and remember, Africa is the oldest continent with the youngest population. If we do not sort out that problem right now, it's going to be a disaster for all of us. Thank you.
Thank you, Malinga. And one of the things that I just want to also thank my own staff before thanking everyone is just because they endlessly work behind the scenes, both Irene at Nigeria, others who are based and online working with the partners to staff them, those who have staffed online, and then also Taylor, Francesca, and Jose that you see here. Thank you. But I do want to give the final words to our co-host on the Sustainable Dialogue on Peaceful Uses to add some additional words related to kind of Ghana. We do have Zambia and Nigeria as a case study, but you're thinking around Ghana and other things.
Right. If the goal here was to learn, I can definitely say mission accomplished in that regard. The country is large and the needs are many. Should be a call for everybody in the development sector at large, because no matter where you are, that's the case. Ultimately, what I see from a sustained dialogue perspective is it is only a portion of the problem that everybody here is designed to address, and we want to be partners in addressing some of those problems using, identifying. Again, we're playing hide and tell, or hide and seek, not show and tell. Backwards. We're playing show and tell, not hide and seek with the name. It is about peaceful uses, and that's what we're looking to build champions for around nuclear technology. That's a portion of everything that was talked about here today, and we want to help with that. I completely agree with the call for tangible actions and next steps, because if nothing else, if I forget everything else about this, the one thing this one statistic I will not forget is that 800 women a day are dying during childbirth. In the time we've been sitting here, 200 women since 7:30 this morning. If that is not a catalyzing number for what we're trying to do here, I don't know how to reach somebody as a call to action. So anything that our little slice of U.S. government funding can do to make an impact on that number, because if there's one thing that everybody here, no matter where we came from, has in common, we all have a mother. And that we owe it to our mothers and everybody else's mothers to do what we can to make that process safe. we're not going to solve, none of us here are going to solve that entire problem. But I can guarantee you our program is going to do everything we can with our little bit of government funding to help. And so thank you all as a citizen, as you said, Robert, thank you for what you are doing to solve these problems. It can feel like you're trying to boil the ocean sometimes, I know, but it's the call to action, the stars aligning, people coming together to have these conversations, it's the next step, so that maybe someday that number's 700 and trending downward, and that's all we can hope for. So thank you very much, Joanna, for pulling this together, bringing together an incredibly diverse group of people, knowledge, skills, experiences, and helping to inform what this program is going to do, but also build a better program going forward to address these challenges. So thank you very much as well.
No, thank you to you, and thank you to Dr. Ted and Dr. Key, because it's been a journey that we couldn't do alone or without expertise around the table. And I think we look forward to kind of taking each of you in groups of 4 or 5, not big meetings, you're not going to hear about us publicly for a little while, but just kind of diving into each of these case studies.
Yeah, again, I want to thank everybody, and and as well as for coming and being willing to share your ideas as well as what you've accomplished, and your suggestions for next steps. So I think we're all energized and look forward to working together. Key?
Thank you. Yeah, so we work with a number of ministries of health, and they've developed these massive plans. And struggling with ministries of finance to fund it. And then we've become aware of this thing called Pledge for Responsible Investing, right? It's $90 trillion or something like that. I'm probably off by zeros. I'm also not very good at money. And then those people who pledge that, they want to help reach these sustainable development goals. And then they look at health sector, and the health sector investments have been anything but effective in many ways, because they invest in things like private hospitals. They say we're investing in health, but that doesn't address the people who are being left behind. So there was this massive gap between the money and the need. And I'm like, how are we going to bridge this gap? But I think this is what's happening here in this room. I see the other side now. I can start to see people on the other side going, hey, it's almost close enough to jump over. I think we're there. Thank you all.
Thank you so much. And Jeffrey, I see you joined us before we log off. Any final words?
Oh, thanks. I've been here the whole time, but I figured that I'd not give too much attention to myself. But with that said, I just want to thank you all. This has been a truly exceptional session, and really paves the way shortly as I actually jump on the plane and join you not too long from now. And really, I think the idea of following up perhaps in those trusted circles with the extraordinary cases that were identified, but also recognizing, and I think we all drink, and many of you have created and stir the Kool-Aid, is doing business not as usual. Recognizing that as we opened up, coming from the spring meetings with IMF, World Bank, where we're dealing with tight fiscal spaces. And so how do we create those innovative models where there could be perhaps even some restructuring? We know Zambia has been mentioned several times. They also were leaders at those spring meetings around how they were restructuring debt so that some of that could go towards actually human resources for health. But then enabling policies that we know on the ground that could be exceptionally helpful in the last mile in terms of how we look at alternative supply chain, not just from public medical stores, but from private sector. And with that said, I think I'll end with the magnificent comment that one of the colleagues just shared earlier was the magic, as we know, is not anyone wearing a tie or a suit from the Beltway or other places. It's really the frontline Shiros delivering the services and also the voices of the clients. And I'll say that very briefly that I had just gone through a series of site visits through different countries that we operate in sub-Saharan Africa, and saw such extraordinary impacts and transformation using fintech around leveraging national health insurance and private insurance. And I think that we can all feel very optimistic about what comes next, especially as we ideate together in these smaller groups with the cases and seeing where we could scale for impact. And with that said, thank you so much. This has just been a really fantastic and wonderful session to join in.
Thank you, Dr. Jeffrey, and maybe while you're coming to Geneva, we may borrow some of your time. I know you're probably in back-to-back meetings in those smaller case studies to discuss with you and take advantage of the time that we are all together.
Delighted. I think I've demonstrated I don't need a whole lot of sleep, so it's all good.
Okay. So onward we go all together. Thank you to everybody.